Hello friends, so now we are going to learn about respiratory radiology and starting with the first one, the various modalities that we have here. So chest x-ray, that's the initial investigation that we do in any patient with chest complaints. So what is the routine chest x-ray view that we do? The routine chest x-ray view is the chest x-ray PA view, that is the posterior anterior view. For foreign body, we do inspiratory and expiratory chest x-ray view. The routine chest x-ray is a PA view in full inspiration, and here it is inspiration and expiration both, because with foreign body we want to see that on which side the air is not going out, suggesting a block on that side. So inspiratory and expiratory both. For pneumothorax, expiratory chest x-ray is better than the inspiratory chest x-ray, because in expiration the white lung gives a good contrast to the black pneumothorax. For pleural effusion, the chest x-ray view, which is the most sensitive, is the same side lateral decubitus view with horizontal beam. Always with lateral decubitus, it is a horizontal beam. So if it's right pleural effusion, right lateral decubitus, left pleural effusion, left lateral decubitus. For right middle lobe collapse, we have the lordotic view or the apical view. Lordotic or apical view helps in the evaluation of the apex of the lung, that is like Pancoast tumor, or even the right middle lobe collapse. Now, coming to the CT scan, which is the best investigation when it comes to lungs and especially the anterior mediastinum. So, expiratory CT we do when we are suspecting obstructive airway pathology. So, what we will see is with the obstruction in expiration, the air does not go out. So, we will see findings of air trapping. The air will be trapped, giving mosaic pattern of attenuation. Mosaic attenuation is what we would see. Prone CT heads in two conditions. One is aspergilloma, that is fungal ball. It is a mobile fungal ball that we would see. So when we see the air crescent sign, the monod sign, and you want to prove that this is fungal ball, we ask the patient to go prone so that the fungal ball moves and goes to the dependent part. Second, the prone CT helps in differentiating the dependent densities in the lung versus the early ILD features. So, early ILD starts in the dependent part of the lung. With gravity in the supine position in CT, we might see the dependent densities. So, to differentiate the two, we do a prone CT. If it is ILD, it will be still persistent. If it was just the dependent densities, it will go away. Next, HRCT. HRCT is best for interstitial lung disease and for bronchiectasis. So, wherever we want to see for lung architecture, HRCT is the best. CECT is done for any space-occupying lesion, any infective pathology, inflammatory pathology. We do a contrast-enhanced CT, right? Now, where do we use MRI? Very, very important recent NEET PG question as well. MRI is done for Pancoast tumor, the lung apical tumor. So, for Pancoast tumor, we do MRI basically to look for brachial plexus invasion. Okay, to look for brachial plexus invasion. MRI is also the investigation of choice for posterior mediastinal mass. Because what is the most common posterior mediastinal mass? Neurogenic tumor is the most common, and nerves neurogenic MRI is the best we know for soft tissues. Versus for anterior mediastinal mass, it is contrast enhanced CT, which is the investigation of choice, right? Now, coming to the whiteout and the blackout hemithorax. Now, what are the causes of whiteout? So, consolidation, collapse, then we have pleural effusion, pneumonectomy. These are the causes of whiteout. So, whenever the air is replaced by something more dense, or the air is completely removed like in collapse, or there is fluid like pleural effusion, we get whiteout. So, the whiteout hemithorax, how do we differentiate the causes? Is based on the tracheal shift. It is based on the tracheal shift. So, in consolidation, the trachea is in the center. Remember, there is no shift in consolidation. So, when you would see that trachea is in the center, then it is consolidation. Plus, the other finding that you see here, the black lines through that white opacity, that is the air bronchogram sign. So, air bronchogram sign without tracheal shift is consolidation. Next one, here we see that the trachea is pushed to the opposite side. And we have this white opacity, the blunting of the costophrenic angle. This is pleural effusion, tracheal shift to opposite side. Here we have the wide out hemithorax, trachea is pulled to the same side. This one is collapse. So collapse causes volume loss and pulls the trachea to the same side. Similarly, here also we see the trachea is shifted to the same side of wide out hemithorax. Another cause similar to collapse, this is going to be pneumonectomy, that is lung removal surgery. So the lung is removed, the air is removed, and so even pneumonectomy gives the white out hemithorax with the same sided shift. Now coming to the blackout hemithorax. What causes blackout hemithorax? Black on X-ray is air. So excessive air like in pneumothorax, emphysema. Then we have the next, decrease the density will cause blackout. Why? Because when we decrease the density, we know that the image comes black, right? The X-ray penetration is more and the image is more black. So here in this image, what do we see is, look at this image here. Here we see the right breast shadow. The left breast shadow is not seen, suggesting that left mastectomy has been done. So look at how the lung, the black lung, the left lung is appearing more black as compared to the right lung. So mastectomy is one of the cause of blackout, or basically any cause of decreased density. So one is mastectomy. The next is Poland syndrome, where we have congenital absence of pectoralis major. Next is the increased air wale causes, like in this case we see this visceral pleural line and there is this jet black air without vascular markings. So that is pneumothorax. Then we have COPD or emphysema, where because of the excessive air, it's an obstructive airway pathology. So the excessive air, there is hyperinflation of the lungs. The lungs are hyperinflated. The diaphragm is flat because of the hyperinflation causes the pressure on the diaphragm. The diaphragm becomes flat. The heart becomes more tubular, elongated tubular heart. All these are findings with emphysema. But remember, emphysema is generally bilateral. It's not a unilateral blackout. Next cause of blackout is the decreased vascular markings, right? So if you remove the vessels, the white vessel markings, that area will become black. So where do you have decreased vascular markings? In pulmonary embolism. So pulmonary embolism, massive pulmonary embolism can cause one lung appearing completely black on that side, right? So that sign in pulmonary embolism where we have focal oligemia, we are seen in CVS radiology. It is Westermarck sign, vascular mark. Read it as vascular mark decreased. That is Westermarck sign. So here we see the black area as compared to the other side. Okay. So remember, these are the causes of blackout. Pulmonary embolism is blackout, not whiteout. Pneumothorax is blackout. Remember that. Now going to the next pathology, that is pneumothorax. Now pneumothorax, the general history that is given is a history of trauma. Right. And now the patient has chest pain, breathlessness, blood pressure can be low because of obstructive shock. What is the most sensitive investigation for air containing pathologies? It is CT scan is the most sensitive, but we don't do CT scan the first. Right. In a patient of trauma in emergency, the first thing that we have is fast and E-fast. What is E-fast? E-fast is extended fast. What is the extended part here? It is extended to include the thoracic or the pleural cavity to look for pneumothorax, hemothorax, right? What is the X-ray view that we do for pneumothorax? It is the expiratory view, which is better because we said in expiration, the lung becomes white. The white lung gives a good contrast to the black pneumothorax, right? So that is why expiratory chest X-ray is better. Immediate management is what is asked. The first step in the management is the needle puncture. The needle puncture is we should do in the 5th intercostal space in adults and 2nd intercostal space in children, right? Now, what do you think would be the answer to this question? The ultrasound sign of the condition shown in the image is, so this is the collapsed lung here and this surrounding one is the pneumothorax. The lung collapses towards the hilum. This is the visceral pleural line. So the ultrasound sign, we have lung point sign, barcode sign, stratosphere sign. We have all of the above signs. Let's have a look at these. So the first image here, this again is the visceral pleural line with the collapsed lung and this is the pneumothorax. This is the pneumothorax on the right side causing the mediastinal shift to the opposite side. This is a CT scan which is showing this black air. Air is black on CT. There are no vascular markings. Look at how the normal lung has the vascular markings. So this is CT showing left-sided pneumothorax. This one is the deep sulcus sign that we are seeing here. So look at how the right sulcus is deep as compared to the left. This is seen in the supine X-ray in a patient of pneumothorax. So in ICU patients who cannot stand erect, we do the supine X-ray, and the pneumothorax is detected by the deep sulcus sign. The air going into the sulcus makes it deep, right? You can see the black air in the sulcus. Now this is the M mode of ultrasound, right? The M mode, which is done for the movement of these structures. Normal lung without any pneumothorax. We will be able to see the movement of the lung with each breath, right? So that gives the granular appearance, like a beach wala appearance. So that is called as seashore sign. So seashore sign is normal. In the lower part, which shows the lung movement, you would see the granular appearance, right? If it is pneumothorax, what happens is the pneumothorax overlying the lung does not allow the sound to penetrate and visualize the lung movement. So in the lower part, you would not see the lung movement. So there would be flat lines like the barcode or the stratosphere. So look at the lower part. You will see the flat lines. So the barcode or the stratosphere sign is what we see in pneumothorax. If the question is what is the most specific sign, it is the lung point sign. The presence of the lung point is the most specific sign for pneumothorax. What is the lung point? The transition from the normal to the abnormal. That means look at the seashore sign getting transition to the barcode sign. So the point at which this happens, this is the lung point sign, and this is the most specific sign for pneumothorax, right? Now going to pneumomediastinum. Pneumothorax is air in the pleural cavity. Pneumomediastinum is air in the mediastinum surrounding the mediastinal structures like the heart, trachea, esophagus, right, thymus, all of those. So pneumomediastinum, the most sensitive investigation, again because it is air containing, the most sensitive investigation would be CT. The cause that we should remember for pneumomediastinum is Boerhaave syndrome, which has complete esophageal tear and not the Mallory-Weiss tear. There are multiple other causes. One of these we should remember is Boerhaave's, right? Now look at these images. The first image here, this is a CT scan. This is the arch of aorta, and you can see the black air surrounding the aorta, which is a mediastinal structure. So this is pneumomediastinum, right? This is pneumomediastinum surrounding the trachea, the arch of aorta. What sign of pneumomediastinum is shown here? Look at how the air is separating the heart from the diaphragm. So the diaphragm can be seen completely, right? So this is called as continuous diaphragm sign. A previously asked question, continuous diaphragm sign is seen in pneumomediastinum. Next, what is this sign here? So here you can see this V-shaped air, V-shaped accumulation of air. So this one is the Necklerio's V sign. This is the Necklerio's V sign in pneumomediastinum, where there is air in between the aorta and the diaphragm, the V-shaped air. This one here, this is the heart, and this is the thymus, which is separated from the heart because of the air. So this is called as Spinnaker sail sign or the angel wing sign. So when the thymus gets separated because of the air in the mediastinum, that gives the Spinnaker sail sign or the angel wing sign. And what are we seeing here? So pneumomediastinum can go into the subcutaneous tissues, also lead to subcutaneous emphysema. And look at these, the linear striations that you are seeing in between the fibers of pectoralis muscle. This is called as the ginkgo leaf sign. Okay, that's the ginkgo leaf sign, which has those multiple striations like this. So this is the ginkgo leaf sign. Look at the black air in the tissues in the neck, so suggesting subcutaneous emphysema. And clinically, what do we see in subcutaneous emphysema? The Hammann's crunch, right? Subcutaneous emphysema, clinically we would feel the Hammann's crunch, right? Now going to pleural effusion and hydropneumothorax. So for pleural effusion, what is the most sensitive investigation? So for fluid containing pathologies, fluid, U for ultrasound. So remember, for water, for fluid, ultrasound is the most sensitive investigation. What is the most sensitive chest X-ray view? We have seen that it is ipsilateral lateral decubitus with a horizontal beam. So this X-ray view that we are seeing is the right side down. So this is right lateral decubitus. So this is done for which pathology? Right lateral decubitus will be for right pleural effusion. right? And this will be done with the horizontal beam. The beam goes horizontal, not vertical. Always with decubitus, it is horizontal beam. Okay, just horizontal beam. So look at this radiograph. What it is showing is this white is the fluid. Because of the decubitus position, all the fluid has come in the dependent part. So this is how the pleural effusion will be on decubitus X-ray. Now look at the various appearances in pleural effusion. The first thing on the chest X-ray PA view, which actually is the least sensitive X-ray view, is the blunting of the costophrenic angle. Look at the normal costophrenic. We are not talking about cardiophrenic. Costo means the ribs and phrenic means the diaphragm. So look at how the costophrenic angle is sharp. Look at this one, how the angle is blunted because of the fluid here. So the first finding in the chest X-ray PA view is the blunting of the costophrenic angle. Now as the fluid quantity increases, what happens to this fluid level? The upper margin is not horizontal. It is horizontal in hydropneumothorax, HH. It is curved or it is S-shaped in pleural effusion. So what do you see is the upper level is going like this. The lateral side is more up. The medial side is more down. This is called as LSS curve, or this looks like a meniscus. That is hallmark of pleural effusion. Very, very frequently asked. The next that we have is if you see this D-shaped curve, right? If the fluid is like this with a D-shaped curve, then it is suggestive of loculated pleural effusion. That means that the fluid is not able to go ahead. It is loculated. We will see a lot of septations when we do ultrasound. Okay, ultrasound will show the septations. This one here, classical appearance where you see this biconvex or lentiform shaped fluid accumulation in the horizontal fissure, the right horizontal fissure. This is suggestive of fissural effusion, also called as phantom tumor, which is seen in cases of left ventricular failure because of the fluid accumulation. Phantom tumor, also called as vanishing tumor, because it vanishes when we give diuretics, right? It does not need any surgery. So this is the classical appearance here. Now this is the CT scan, which is showing this gray, that is a water density fluid accumulation in the dependent part with the meniscus appearance, right? You can see this meniscus appearance. So this is bilateral pleural effusion, gray water density. How do we differentiate pleural effusion from empyema? What is empyema? An infected pleural effusion containing pus. So what happens in empyema? Because of the pus, it causes the inflammation of the surrounding pleura as well. So the pleura gets thickened and with contrast, it enhances. So with empyema, what will we see is the pleura will have this thick and enhancing appearance. Normal pleura will not be thick and enhancing. So this suggests that this is empyema, which is splitting the pleura apart. So this is called as split pleura sign, which is suggestive of empyema. This is split pleura sign suggestive of empyema. So how can we differentiate empyema from pleural effusion? Ultrasound is a good investigation. It will show the echoes and the septations in a case of empyema. Okay. Now, going to this pleural pathologies, a quick review. So when you have this S shape or the meniscus curve, then it is pleural effusion. When it is horizontal level, there is blunting, but horizontal level, remember H for H, horizontal is hydropneumothorax. And when you have this black appearance with the visceral pleural line, the collapsed lung, then it is pneumothorax. Okay, then it is pneumothorax. So pneumothorax is the one which will give a hyper-resonant note on percussion. Another important clue in the clinical history, pleural effusion, because it is water, it will give a dull note on percussion, right? Now going to the lung pathologies, how do you localize a pathology? Whether it is intraparenchymal, extraparenchymal, even if it's intraparenchymal, in which lobe of the lung it is, how do we localize on X-ray? So the sign which helps in localizing whether this is parenchymal or extraparenchymal pathology is the air bronchogram sign. Now air bronchogram sign is present in parenchymal pathologies. Okay, air bronchogram is present in parenchymal pathology because the bronchi are present in the parenchyma, not outside the parenchyma. So what is the air bronchogram sign? Air containing bronchogram means the bronchi. So we see the air containing bronchi. Normally also the bronchi contain air. So what is different here is the air containing bronchi are seen very well because in the background, in the surrounding, we have the white lung. So air bronchogram sign basically is the white lung giving a good contrast to the black bronchi, right? Radiology is all about the black and white contrast, right? So any condition where the lung becomes white and the bronchi are patent containing air, we would see this air bronchogram sign. Example, consolidation. Any cause of consolidation like pneumonia, pulmonary edema, it's water, consolidation, hemorrhage, even hyaline membrane disease. We know that it causes white out lungs, right? So it gives air bronchogram sign. Remember that this will not be seen, one of the recent NEET PG question, air bronchogram will not be seen in pleural effusion or mediastinal mass because they are outside the parenchyma. How do you identify the air bronchogram? Look at this white lung and look at the black bronchi going through it. Look at this opacity, the white opacity, and through that you can see the black markings representing the bronchi, telling you that this is intraparenchymal pathology, right? Now, this one, what do you think? This is parenchymal or this is extraparenchymal? Here in this image, we are not seeing the air bronchogram sign. It's white out, but no air bronchogram. So this is extraparenchymal. This is the white out hemithorax with the trachea shifted to opposite side, right? So this is suggestive of pleural effusion. White out with trachea shifted to the opposite side and air bronchogram sign is absent. This is suggestive of pleural effusion. Now, how do we differentiate whether it's a consolidation or it's a collapse? Both of them look white. Consolidation, because of the solidification, the density increases, looks white. Collapse, because the air is removed, the black part is removed, so even collapse looks white. So how do we differentiate whether it is right upper lobe consolidation or collapse? Now, consolidation the volume remains the same. We are just replacing the air with something else. So there will be no shift of the structures, no fissural shift, no tracheal shift. Collapse, because there is volume loss, it will pull the structures towards itself. So fissural shift to same side, tracheal shift to same side. So consolidation will be no shift. Collapse will be same-sided shift. That is what we would see in collapse, right? Now, let's have a look at these images. What are we seeing here? So, in both of these images, there is an opacity. There is an opacity in the right upper zone, limited by the fissure. So, above the horizontal fissure is the right upper lobe. Now, because the fissure is in its position, the horizontal fissure, that is why this is right upper lobe consolidation, because the fissure is maintaining its position. Here the horizontal fissure has gone up. It has been pulled up by the opacity. So that means this is the right upper lobe collapse, right? This is the right upper lobe collapse. Now what is this? Is it consolidation or collapse? You are seeing the trachea getting pulled to the same side of the opacity. We can also see this another sign here. Look at the diaphragm, which appears like a tented diaphragm. Tenting of the diaphragm, also called as juxtaphrenic peak sign, which is suggestive of collapse. So it pulls the trachea, it pulls the diaphragm. So that is suggestive of collapse. Juxtaphrenic peak sign and the tenting of the diaphragm. Now, how do we localize the lobe on the X-ray? Right. Now, whether it is right upper lobe, middle lobe, lower lobe. So, in lobar localization, what comes to our rescue is one, the fissure ka position, and second is the Silhouette sign. Let's have a quick look at the fissures here. Now, right lung versus left lung. Right lung has two fissures, that is the horizontal fissure and the oblique fissure. Left lung has only the oblique fissure. So, oblique fissure is the one which is called as major fissure, which is present on both the sides. Horizontal fissure is called as the minor fissure, right? So, above this horizontal fissure, the lobe of the lung that you are seeing is the upper lobe. Below the horizontal fissure, we have the right middle lobe. Both of these are present anterior to the oblique fissure. So, if you have a look at the lateral chest X-ray, oblique fissure ke aage is the upper and the middle lobe. Piche is the lower lobe. So, posterior part predominantly is the lower lobe, right? So, lateral chest X-ray, if you see an opacity which is overlapping the heart shadow, the heart is somewhere here. then it means that it is right middle lobe pathology. Very, very important. How do you differentiate its right upper lobe versus right middle lobe? On a PA chest X-ray as well. Horizontal fissure के ऊपर is the right upper lobe, नीचे is the right middle lobe. So, right upper lobe is above the horizontal fissure, right middle lobe is below the horizontal fissure. If in a lateral X-ray, you see that the pathology is overlapping the vertebra, that means it is the posterior lobe, and which is the posterior lobe? It is the lower lobe, and that is why what we also see in a lower lobe pathology is the spine sign. Okay, the spine, the vertebra will become more white. Normally it should start becoming more black as we come down. If the vertebra becomes white below, then it means that it's a lower lobe pathology. That is the spine sign. Okay, that's the spine sign. Now, let's have a look at these images. What do you think? What lobe pathology is this? This is the horizontal fissure. The opacity is above that. So that means this is right upper lobe, because below that is the right middle lobe. Because the fissure is in its position, it's not shifted. That is why this is right upper lobe consolidation. No shift is consolidation. What do we see here? Look at this one. Horizontal fissure, opacity below that. Look at the lateral chest X-ray. This is the oblique fissure. The opacity is anterior to that and overlapping the heart. So this is right middle lobe consolidation. Below the horizontal fissure, anterior to oblique fissure and overlapping the heart. Okay. Now have a look at this one. Here we see an opacity on the left side. On the lateral chest X-ray, you see that it's overlapping the vertebra, causing the lower vertebra to appear more white. This is the spine sign. Posteriorly located, this is going to be the lower lobe. Okay, this is going to be the lower lobe. Now, the other sign which helps in lobar localization is the silhouette sign. What is the silhouette sign? The loss of the border sign, basically. So, when you have two equal density pathology structures coming together, the intervening border is lost, right? जब ये orange color साथ में आ गए, then the intervening border is lost. When they are different colors adjacent, different densities adjacent, the border is maintained, right? So, when the right heart border is lost by any pathology, then it is right middle lobe pathology, right? So, if the pathology is obscuring the right heart border, it is a right middle lobe pathology. If it is obscuring the left heart border, then it is the lingula pathology. Remember, we don't have the left middle lobe, right? It is the lingula on the left side corresponding to the right middle lobe. If the pathology is obscuring the diaphragm is down. So, it is the lower lobe. So, right diaphragm, left diaphragm, it would be the lower lobe. If the pathology is obscuring the ascending aorta on the right side, it is the right upper lobe. Aortic arch, this is on the left upper lobe. Okay, left upper lobe. So, remember, that's the silhouette sign. Look at these images here. Recent NEET PG exam question. You see the pathology obscuring the right heart border is not well seen. This is the right middle lobe causing silhouetting of the right heart border. Here, it is the left heart border which is silhouetted. The diaphragm is seen very well, so not the lower lobe. This is the lingula pathology obscuring the left heart border. Okay, obscuring the left heart border. Now, let's come to the signs in the various lobar pathologies. First one, the golden S sign. Look at this one. The fissure is appearing like the S. The reverse golden S sign is also what it is called as. Normally, the fissure is horizontal. With the collapse, the fissure should go up uniformly. But here what is happening is the fissure is going like this. Why? Because in the medial part, we have a mass which is not allowing the fissure to come up. So, the golden S sign suggests that the collapse is because of some central mass causing the obstruction of the bronchus, and more likely this is a bronchogenic carcinoma. Okay, it's a bronchogenic carcinoma. So, this is the golden S sign with the collapse of the upper lobe. You can see the upper lobe appearing white. Next is the Lufsischl sign. Now, remember Lufsischl, L-U-L-U. This is seen in left upper lobe collapse. It is seen in left upper lobe collapse. So, with the left upper lobe collapse, what we will see on the lateral chest X-ray is anterior to oblique fissure. It will be collapsed, the white thing that is called as wheel-like opacity on the lateral chest X-ray, anterior to oblique fissure. So what happens? The lower lobe of the left lung gets hyperinflated to compensate. And the part of the lower lobe now comes adjacent to the arch of aorta. So this is what you see here, the sickle-shaped air surrounding the arch of aorta. That is the left sessile. Sessile is like sickle of air. Okay. Flat waist sign. It is seen in left lower lobe collapse. So when the left lower lobe collapses, the left heart border, the left mediastinal border becomes flat. Okay. So that is called as the flat waist sign. Okay. That is the flat waist sign. Now, let's learn about bronchiectasis. So, bronchiectasis, as the term says, is ectasia, that is dilatation of the bronchi. The clinical features we have, generally this is more common in elderly because of the weakening with the age of the bronchial wall. The patient presents with cough. There can be sputum as well. And the most common lobe affected is the lower lobes, right? It is more common in the lower lobes. And the best investigation for bronchiectasis, because it's a lung architecture problem, it is HRCT, which is the best, and not bronchoscopy. Now, normally what happens is a bronchus, as it goes into the periphery of the lung, it tapers down. But with bronchiectasis, what happens is this tapering is not there, so the bronchus lies parallel. The tapering goes off. So anywhere we see two parallel lines, it is called as tram track sign. So look at this one, lower lobes predominantly. We see this tram track sign. The tram track sign is what we are seeing here. Look at the CT as well. You see the bronchus, which is showing this tram track sign. So tram track sign is bronchiectasis. Here what do you see is, look at this one, the other sign that we have. Now adjacent to the bronchus, we have a vessel. Normally, they are of the equal size. With bronchiectasis, what happens is the bronchus becomes larger, the vessel is smaller. So that gives the signet ring sign. The black is the bronchus air containing and we have the small vessel adjacent. So that is the signet ring sign that we see in bronchiectasis. Right. Remember the tram track sign in pathology we have read in MPGN. Right. Signet ring sign in pathology in ovarian tumor we have seen in Krukenberg tumor, right? That gives the signet ring sign. Bronchiectasis can also have the cystic appearance. The dilated bronchi can appear as cyst, which might show this air fluid level because of the mucus within. You can also see at places there is the signet ring sign which is shown. So this is bronchiectasis. Can you identify the syndrome which is having? What is this syndrome? You can see that there is dextrocardia here. And actually there is situs inversus. The stomach bubble is also on the right side. So there is situs inversus and we see this dilated bronchi. So bronchiectasis with situs inversus, we think of Cartagener's syndrome and the associated finding, it would have azoospermia. There is ciliary dyskinesia that we see in Cartagener's syndrome. Now coming to how do you differentiate choanine trachea versus choanine esophagus? Now, esophagus, when I write esophagus OE, remember the O is the circle. So, in the AP view, the coin appears circular. When we write trachea, the T is like a slit. So, in the AP view, the coin appears like a slit. Opposite happens in the lateral view. Circular coin, a circular coin laterally, right? So, if this is the coin that we have, if this is circle, laterally if I see, it just appears like a slit. If this is slit on AP, laterally if I see, it appears circular, right? So just remember the AP view, the lateral view will be opposite. So esophagus circle, trachea is slit, right? So let's have a look at this one. If in the AP view, it is slit like, lateral view is circular, this is trachea. Esophagus, circle on the AP view and it is slit like on the lateral view. Now going to next one, tell me what do you think? This is esophagus or trachea coin? Because it is circle on the AP view, this is the coin in the esophagus. Now going to the next one, the next pathology that we would be seeing are infections. First one, what are we seeing here? The bulging fissure sign. So look at this horizontal fissure which is bulging down. Normally it should be horizontal. Why is it bulging down? It's because of this Klebsiella pneumonia. Klebsiella, also called as Friedlander's bacillus, which has a lot of mucoid colonies, a lot of viscous sputum that causes the pressure on the fissure and causes the bulging. So bulging fissure sign is Klebsiella. The background history that you generally have, this is an alcoholic patient, जिसमें aspiration हो सकता है, and The sputum that we have because of the mucoid, it is the current jelly sputum. Okay, that is the current jelly sputum is what we have here. What do we see in the next radiograph is the pneumatocoel. Look at this thin-walled air-containing cavity. Pneumatocoel is common with staphylococcal pneumonia and also with pneumocystis carinii. As the term says, pneumocyst has pneumocyst, that is pneumatocoel. With PCP, the background history would be it's a HIV positive patient with CD4 count less than 200, right? It is more common in the bilateral perihilar regions, which can show bilateral perihilar ground glass opacities, and there can be pneumatocoels. Coming to tuberculosis. Primary tuberculosis, the Gons focus, the hilum is bulky, right? So you might see the bulky hilum, and then there can be the cavity also, which is a feature of secondary TB. So cavity with the surrounding fibrosis, this is fibrocavitatory TB with asymmetrical hilar lymph nodes. If you have symmetrical hilar lymph nodes, then we think of sarcoidosis. Next one is this miliary pathologies, bilateral miliary mottling, which is miliary TB, which is seen with hematogenous spread of the infection. Remember, it's not specific for TB. Next, when we have the active endobronchial spread of the infection, the endobronchial spread then leads to the formation of those nodules, and this is called as tree in bud appearance. So look at this one. We have this tree in bud appearance. Which is suggestive of active endobronchial spread of the infection. Next, TB we know causes necrosis, caseous necrosis. So what do we see here is, this is the aorta. This is a contrast CT with the aorta containing contrast. The surrounding ones are the lymph nodes. What pattern of enhancement are we seeing with lymph nodes? Not complete, but peripheral enhancement, ring enhancement, because in the center they are necrotic. So these are necrotic mediastinal lymph nodes, and we also see this bilateral pleural effusion, right? Exudative pleural effusion is what infections cause. So necrotic mediastinal lymphadenopathy. Now coming to hydatid cyst caused by echinococcus. Hydatid cyst, various signs we have. It can appear like this, just a cyst. With the rupture of the membrane, there can be this water lily sign. So air fluid level with the water lily floating. The membranes can appear like a snake. That is the serpent sign. There is Cumbo sign, rising sun sign, meniscus sign. These are the various signs that we see in hydatid. Most important image here. Look at this lesion with the air and with the fluid level, and on the fluid there is something floating. So this is the water lily sign, which is suggestive of hydatid. Remember, hydatid in lung does not calcify. It does not calcify. Coming to aspergillus, which is a fungal infection. For aspergillus, remember the most important point, aspergillus, when I write A, it has this acute angle and it has a horizontal line, the septation also. So this is acute angle branching with septations. That is the most important clue for aspergillus. Now in ABPA, that is allergic bronchopulmonary aspergillosis, allergy increases the mucus production, right? So what do we see is, the bronchi are dilated, bronchopulmonary. So it will have bronchiectasis. Remember, ABPA causes central bronchiectasis. That means the main bronchi are dilated and they are filled with mucus or the high attenuation fungal elements. So that gives the finger and glove sign, right? The fingers are the bronchi filled with the mucus, the white gloves. So this is the finger in glove sign. This is also called the ham sign, the high attenuation mucus inside the bronchi, right? So this is finger in glove sign. Next, with aspergillus, we have aspergilloma or the fungal ball, which comes in the pre-existing cavity, like a patient of TB having a cavity in the lung. The fungus comes and forms a ball there, aspergilloma. So what happens that within the cavity, the fungal ball comes and sits. So the remaining air that we have, it forms a crescent. So what do we get is this air crescent sign, this air, the black air appearing like a crescent. So what it gives is the air crescent sign, also called as the Monod sign, And we said that initially, how do we prove this is aspergilloma? By prone CT. This is going to be mobile on prone CT. Next, in immunocompromised patients, we get the most severe form of aspergillus infection, that is angioinvasive. So with the invasion of the vessel, the lung develops the infarct and the surrounding hemorrhage. So what we get is this infarct in the center that appears like a consolidation, and surrounding the infarct, what do we have is the halo. Okay, that forms the halo, the hemorrhage that is forming the halo. So infarct surrounded by hemorrhage, that gives the halo sign. So angioinvasive is the halo sign where you have the infarct, consolidation and the ground glass opacity. What is the difference between consolidation and ground glass opacity on radiological finding? Consolidation is dense white, solid, dense white. So it obscures the background vessels. Ground glass is gray. That means the white vessels can be seen through it. So if you see here, you can see the white vessel here, right? You can see the white vessel here. It is not completely white. So that's the difference in between the two. Now, going to, where do you find the reverse halo sign? हमने कहा कि halo sign is consolidation surrounded by the ground glass when it becomes the opposite. That means the periphery is more white as compared to the center. Then it is called as the reverse halo. The halo comes inside. That means it is the ground glass opacity which is now surrounded by the consolidation. That is the reverse halo sign. And this is seen with cryptogenic organizing pneumonia. It is seen with COVID-19 as well. COVID can show multiple appearances. It can show the halo also and the reverse halo also. But what is the most common finding that we saw in COVID-19 patients in HRCT, which was suggestive of CORADS 5? That means high probability of COVID-19 being there. It was bilateral peripheral ground glass opacities, right? So in both the lungs peripherally, we saw the ground glass opacities, and it was the most common finding, and the CORADS was used for COVID-19 probability. Remember, the CORAD score is not for severity. It is for the probability whether COVID is present or not present. And what was CORADS 6? 6 matlab it's already a proven case. So this is a case which is RT-PCR positive. RT-PCR positive. Right? Other common infection that we saw in COVID-19 was mucormycosis, especially in patients who have taken steroids or diabetic patients. And remember, mucormycosis called as the black fungus. Black because it causes necrotic areas, because of the angio invasion. And we have the black turbinate sign. Okay, so the turbinate became necrosed. So black turbinate sign suggestive of mucormycosis. It can go into the orbit, it can go into the brain as well. Now coming to the next point, where do you see popcorn calcification in the lung? Popcorn. Imagine like it is like hamara tumara popcorn, that is hamar tomar, that is hamartoma. Hamartoma, pulmonary hamartoma gives popcorn calcification. In the breast, popcorn calcification is fibroadenoma. In the pelvis, popcorn calcification like fibroadenoma is the uterine fibroid. In MRI brain, popcorn calcification is cavernoma. And in bones, which tumor has popcorn calcification? The chondroid tumors like chondrosarcoma. Chondroid tumors like chondrosarcoma, they have popcorn calcification. Now coming to air fluid levels, how do you differentiate? If you have a lung lesion with air fluid level, the first DD that you think of is lung abscess. The patient will have high grade fever. Drug of choice is clindamycin. If you have the lesion with air fluid level with something floating, that is the water lily sign. Water lily sign suggestive of hydatid. If you have the air fluid level, the entire hemithorax, then it is hydropneumothorax. H for H, it has the horizontal level. Coming to interstitial lung disease, the general history here is shortness of breath. How is the cough? It is dry cough. It is not productive cough. Okay, it is not productive cough. There are crackles present. It is dry cough, right? And in interstitial lung disease, the UIP pattern, which has a bad prognosis. UIP, also called as IPF, the idiopathic pulmonary fibrosis. We see this honeycombing appearance, which is suggestive of irreversible fibrosis. So in honeycombing, what we see are these like air-filled cysts stacked one above the other. There is a bronchiectasis. traction bronchiectasis along with it, right? And it basically is seen more commonly in the basal parts of the lung. The peripheral basal parts of the lung is where it is seen more commonly. Like if you see at this one, the peripheral part, the basal part of the lung, there is bronchiectasis, there is this honeycombing appearance is what we are seeing, suggestive of UIP pattern. Versus the NSIP pattern, which has ground glass opacities, but with the subpleural sparing. So you will have the ground glass, but the subpleural area will be spared. And generally with chemotherapy, connective tissue disorders, NSIP is what is more commonly associated. Which is that condition where you have NSIP with esophageal dilatation? That is scleroderma. Scleroderma causes esophageal dysmotility. It can cause esophageal dilatation. Now, do not confuse this honeycombing with crazy paving. The difference between the two is in crazy paving, we have the ground glass opacity with interlobular septal thickening. So, we have the gray appearance of the lung with the interlobular septal thickening like you see here. Look at all these lines that you see. This is the interlobular septal thickening and the lung is not completely black. You don't see the air-filled cyst in the basal part. Versus honeycombing, you will see this black air-containing cyst with the interlobular septal thickening. This is honeycombing, UIP pattern. This is crazy paving. Where do you see crazy paving? Multiple causes like pulmonary alveolar proteinosis. It can be seen in pulmonary edema also, pulmonary hemorrhage also, which can cause the ground glass opacity with the interlobular septal thickening. Right? Now, going to next one, sarcoidosis. The most important clue which is given here is bilateral hilar lymphadenopathy. The first stage of sarcoidosis is the bilateral hilar lymphadenopathy. Then you can have the test like increased ACE enzyme levels. Hypercalcemia is also what we see. It can cause skin lesions like erythema nodosum. That can be another feature, right? So what sign do we see on the chest X-ray is you have the 1, the 2 and the 3 group of lymph nodes enlarged, the right paratracheal, the right hilar and the left hilar lymph node enlarged. That gives the 1, 2, 3 sign, which looks like a garland of lymph nodes. Garland is actually the name of the person who gave this sign, or it is also called as pawnbroker sign. Okay. Now these lymph nodes can undergo calcification in the periphery, peripheral calcification, that is called as eggshell calcification, which can be seen with sarcoidosis, it can be seen with silicosis, also lymphoma, but post-radiotherapy, not pre-radiotherapy. Those show eggshell calcification. Remember that bronchogenic carcinoma does not show eggshell calcification. It's not a malignant calcification. And on HRCT, what you see is the nodules are the perilymphatic nodules in sarcoidosis. So along the fissure which has the lymphatics, you would see the fissural nodularity. So look at this fissure which is having the nodularity. Fissural nodularity, bronchovascular nodularity is what we would see in sarcoidosis in HRCT. Other sign that we can see is the galaxy sign, where you would see a nodule, large nodules surrounded by multiple small nodules like a galaxy. So that is the galaxy sign. What nuclear scan do we do in sarcoidosis is the gallium scan. And what do you see in gallium scan? One is the lambda sign. So the 3 group of lymph nodes, the right paratracheal, the bilateral hilar, they form this lambda sign. So look at this one, like you get this lambda sign, and other sign is this panda sign. Why do you get the panda sign? Because of the enlarged salivary glands, because of the enlarged lacrimal glands, right? And you have the nasopharynx taking the uptake. So the other sign is the panda sign. Do not confuse it with the face of giant panda sign. Where do you see the face of giant panda sign on MRI brain? The face of giant panda sign is seen in Wilson's disease. Okay, that is seen in Wilson's disease. Here this is panda and lambda in sarcoidosis on gallium scan. Now going to asbestosis, which is actually an occupational lung disease with the background occupation history of cement industry or the shipping yard or plumbism. What do we see with asbestosis? Are these calcified pleural plaques. In asbestosis, we see this calcified pleural plaques involving the parietal pleura. So look at this one. These are the calcified plaques. The calcified plaques, diaphragmatic pleura commonly involved, as base is affecting the base of the lung more common, the lower lobes more commonly. These irregular pleural plaques which are seen and face, the sign that it gives, this is called as the holly leaf sign. Okay, the pleural plaques appearing like the holly leaf. These calcified pleural plaques can be well seen on the CT. Look at the calcification along the pleura. And the other sign that we can see here is the comet tail sign, which is seen because of round atelectasis. Round atelectasis. So what happens adjacent to this pleural plaque? The lung gets infolded, forms a round atelectasis. It pulls the vessels towards itself. Atelectasis collapse pulls the vessels towards itself. So that gives the comet tail sign. Remember the comet tail sign on ultrasound abdomen? We saw in gallbladder adenomyomatosis, the cholesterosis of gallbladder. With asbestosis, what tumors do we have? We have mesothelioma, recent NEET PG question. Mesothelioma is the most specific tumor, but most common is the bronchogenic carcinoma. Okay, so mesothelioma history is commonly given. Now coming to lung cancer. In lung cancer, there can be history of smoking generally, which is given, hemoptysis, elderly patient, and the investigation of choice is contrast enhanced CT. For staging of lung cancer, throughout you want to see, then PET CT. What is the gold standard? Gold standard is the CT guided biopsy, right? Biopsy is the gold standard. So what do we see this feature here which is suggestive of lung cancer is this lesion with spiculated margins. Spiculated margins are suggestive of lung cancer. Next, what lung cancer is this in the apex? This is the Pancoast tumor. Here the investigation of choice is MRI to look for the brachial plexus invasion. The history which is given is the arm pain because of brachial plexus involved. There can be ptosis as well because of the Horner's, the sympathetic trunk involved, right? And there can be secondary lung cancer, that is lung metastasis as well, which can appear like this ball-like sized, uniform size. This is called as bilateral. This is cannonball metastasis. Okay, this is cannonball metastasis that we are seeing here. Okay, recent NEET PG question had this question of smoker patient. Lung cancer was given with hypercalcemia. So, which lung cancer has hypercalcemia? Remember, it is squamous cell carcinoma. So, when I write squamous, remember I write it as CA to remember that it has hypercalcemia as the paraneoplastic syndrome associated with it. Now, going to the respiratory distress in newborn, how do you differentiate hyaline membrane disease from transient tachypnea of newborn and meconium aspiration syndrome? Now, hyaline membrane disease, this would be a preterm born baby where the surfactant is insufficient. Remember, surfactant has lecithin, right? Recent question again. So, because of the decreased surfactant, there is lung collapse. The lungs do not inflate. So, it leads to bilateral white out lungs with the decreased lung volumes. And we see air bronchogram sign like we see here. Bilateral white out lungs with the black air bronchogram sign. In transient tachypnea of newborn, as the term says, it is transient. So, it goes off within 24 hours spontaneously. The tachypnea is because of the fluid which is in the lung and in the fissures, right? And the history that we have is the child born by LSCS. In the normal vaginal delivery, the lungs get squeezed through the vaginal canal and the fluid is getting out, squeezed out. But with LSCS, that fluid stays within. So that fluid basically gives the transient tachypnea. So the finding would be basically related to the fluid accumulation. So like you see here, this is a horizontal fissure appearing thick because of the fluid there. There can be some lamellar pleural effusion as well. You might see the sun ray sign, right? Representing those curly A lines. The sun ray pattern is what we can see. So in transient tachypnea, we have the sun ray sign, the fissural effusion. There can be the lamellar pleural effusion. All those findings, the fluid related findings is what we would see. Meconium aspiration syndrome is a post-term baby. Aspirated meconium because the aspiration can go into different sites. So meconium aspiration syndrome will have patchy opacities. Rather than the diffuse or homogeneous bilateral opacities in HMD, here it would be the patchy infiltrates that we would see. It will not be completely white. So some areas will be more white as compared to the rest. So remember that patchy opacities post-term baby is suggestive of meconium aspiration syndrome. If you have a child, a neonate, a newborn with respiratory distress, right, and the other history given is scaphoid abdomen, right, scaphoid abdomen. So scaphoid abdomen is because of the bowel loops going into the thorax. So that is congenital diaphragmatic hernia. Two types, Bogdelic hernia, Morgagni. Bogdelic is the most common. So for Bogdelic, the most common site is the left posterolateral. The left posterolateral. Morgagni, remember RA is right anterior. Bogdelic is ulta. It is left posterior. So Morgagni is right anterior. We would see Morgagni hernia in the right cardiophrenic angle, right? Here, Bogdelic is on the left side. The bowel loops, which appear like this rounded air-filled bowel loops going into the thorax, causing the mediastinal shift to opposite side. So on auscultation, we might feel that there is dextrocardia because the heart is shifted to the opposite side. This leads to pulmonary hypoplasia. The lung cannot develop, and that is the worst prognostic factor in congenital diaphragmatic hernia, right? And here, the bag mask ventilation is contraindicated. The bag mask ventilation is contraindicated. So this is congenital diaphragmatic hernia, very frequently asked. The differential for this is CPAM, that is congenital pulmonary airway malformation, which will also have these rounded opacities in the lung. But in that case, you would see the diaphragm very well. Here you don't see the diaphragm. Okay, there is failure of diaphragm development properly in CDH, right?
Hello friends, so now we are going to do a rapid revision of neuroradiology, a very important system here overall as well as from the radiology perspective as well. So the first one that we are going to see is the various modalities and where do we use which investigation. So how do we differentiate CT from MRI? So CT scan we know is a 3D X-ray, so the bones are white. In MRI, the bone cortex is black. Always focus on the bone cortex rather than on the bone marrow. So here what we see is this is the bone which is white. So this is going to be CT scan. What do we see here is, in this one, do not get confused by the white outline in the image. That white outline represents the scalp fat. And remember that fat appears white on both the T1 and T2. So this is the scalp fat. Where is the bone here? Just adjacent to the brain parenchyma, if you see the black outline, then that is the bone cortex, the sculpca in a table. So if that appears black, that means the bone cortex is black, and so this is going to be MRI. Okay, so this is how you differentiate CT from MRI. Just outside the brain parenchyma is where you should focus. Now, how do you identify the various MRI sequences? First, all these images, there is this black cortex, black cortex, black cortex. So all of these are MRI. Now, if the water is white, so remember WW2, if the water is white, it's a T2 weighted MRI. If the white matter is white and grey matter is grey, that means the anatomy is being followed. Anatomy is a first year subject. So remember, anatomy wala is T1 weighted image. If all is black, that means water also black, the white matter also black, then it's a flare MRI. Okay, then it's a flare MRI. So look at these images. In which of these we have the white water, the image C, where you see the ventricle, the CSF in the sulcal spaces appearing white. So this is a T2 weighted MRI. Here the water is black, the water is black. White matter white. Look at this corpus callosum, the internal capsule, the subcortical white matter. White matter is white, so this one is T1 weighted MRI. Here the white matter is also black, the water is also black, all black, so this is going to be flare MRI. So important, these are the basic sequences that we should be knowing. Next one, DWI and SWI. DWI is diffusion weighted imaging, SWI is susceptibility weighted imaging. Where are these used? DWI is a very important and the most sensitive MRI sequence for acute infarct, and SWI is basically the most sensitive sequence for hemorrhage in MRI. Now DWI looks similar to flare, that means all black. The water also black, the white matter also black, but the difference is you don't see the surrounding scalp fat, the skull bone very clearly, right? While adjacent to the DWI, we also get the ADC map, which is apparent diffusion coefficient. We need to see the pathology on both of these to identify whether there is restricted diffusion. If the signal is opposite to CSF in both the DWI and ADC, then it is called as restricted diffusion. And acute infarct is one of the many causes of restricted diffusion. Remember, acute infarct and not chronic infarct gives restricted diffusion. Next, when in a MRI sequence, you see this black areas. Those are the areas of blooming. Those are the areas of blooming, black blooming that represents hemorrhage or calcification. So what MRI sequences we use for that is T2 star GRE. Okay, we have T2 star GRE and SWI, which is more sensitive. You can see that in same patient, the number of black dots are more in SWI. The advantage of SWI over T2 star GRE is also that it helps us in differentiating hemorrhage from calcification. Both of those give blooming. On SWI, we can differentiate that. So remember that most sensitive for hemorrhage is SWI, and in which head trauma condition we use SWI? Diffuse axonal injury. We would see that ahead. So SWI MRI is the investigation of choice for diffuse axonal injury. Now going to some advanced sequences as well. The first one that we have DTI, that is diffusion tensor imaging, T for tracts. So remember, DTI is used for tracts, the white matter tracts. So what do you see in DTI is these white matter tracts, they appear very colorful. Okay, they appear very colorful. So they help us in evaluating the white matter tracts integrity. This one is bold MRI or functional MRI, which is blood oxygen level dependent. So it helps us in identifying the eloquent areas of the brain. They are activated. So they help us in identifying the functional areas of the brain. The use of this is in neurosurgery planning. It helps in planning for neurosurgery. How much is the safe region to be removed without affecting the eloquent areas? So when in an MRI image, you would see these lighted up areas like this. That is a functional MRI. MR spectroscopy. Spectro gives the spectrum. That is the graph of what? This is a graph of the metabolites in a particular area in a pathology. So based on what graph, what peak we are getting, we can narrow down the differential to the pathology. So normal brain has what peak? Normal brain parenchyma, N for N, normal is NAA peak. In the pathologies, the NAA decreases except in one, that is Canavans. Remember Canavans, the NAA peak increases. In tumors, what peak do we get? Choline peak is what we get in primary brain tumors. In TB, mycolipid, that gives the lipid peak. So TB gives lipid peak. So based on the peak, we can narrow down the differential in MR spectroscopy. What investigation is this? A previously asked question. Now look at this one, the first two images here. This is a routine cervical spine X-ray. Here in the cervical spine, you see some white contrast here in the cervical canal. So that is myelography, X-ray myelography, where what do we do is, like in lumbar puncture, we remove the CSF. Here we do the lumbar puncture and we put iodinated contrast. And then we give the patient head low position so that the contrast goes along the entire subarachnoid space. So that is actually myelography. Okay, this is X-ray myelography. This is the inverted image because any fluoroscopy image can appear black or can appear white. So the black here is actually the contrast. Okay, so again this is a myelography. This is a CT scan with the white bone cortex, and again you can see this white contrast here going into the subarachnoid spaces in the brain as well. So this is a CT myelogram. We can do it under CT as well. And this one is MR myelogram. The advantage of MR myelogram is we can do MR myelogram without contrast. The sequence used is T2 weighted MRI because we want the CSF, the water, to appear white. Same procedure like in myelography, we give the head low position. We can use the same procedure for CT cysternography also. CT cysternogram, which is done to look for CSF leak site, from where the CSF is leaking. Right, so in that cases we can do CT cysternogram. Now in myelography, the various tumors, the space occupying lesions in the spine, they give the various appearances. So quickly telling you about that, the intramedullary tumors, that is within the spinal cord, they will cause the cord expansion. right? And they give this appearance which is called as trouser leg appearance. So imagine like the bell bottom which are flaring out, right? The flared jeans. So trouser leg because of the cord expansion. If it is intradural but extramedullary tumor, which is cord के बाहर लेकिन dura के अंदर, that will give this crescent sign. That gives the crescent sign. And the extradural tumors, सबसे बाहर वाले tumors, they give the feathery appearance. Okay, that gives the feather-like appearance. So these are the various appearances that we should know here. Now going to anatomy, the most important in neuroradiology, we'll have a look at the important sections. So first one is the mid-sagittal section of the brain, where what are we seeing here? What do we see in the mid-sagittal section? So first one here, this is corpus callosum, the white matter tract there. Corpus callosum के यहाँ से जो एक white matter आता है, remember that's the fornix which is located there. Okay, that's going to be fornix. Then what do we have is the brainstem, which is the midbrain, the pons and the medulla oblongata. Pons has the maximum AP diameter that we are seeing here. In front of the midbrain, the small structure MB, midbrain के आगे MB, that's the mammillary body. Okay, that's the mammillary body. This one here is the cerebellum. And in between the pons and the cerebellum, this triangular structure, that is the fourth ventricle. Fourth ventricle connected to the third ventricle by this aqueduct of Sylvius. So remember that aqueduct is the cavity of the midbrain. You can see the aqueduct going through the midbrain, the tegmentum and the tectum. This is the tectal plate, the colliculi of the midbrain. Right? Colliculi is a related splenium of corpus callosum के नीचे we have this pineal gland. Right, so when there is pineal gland tumor, it causes perinode syndrome, the dorsal midbrain syndrome. And look at the relation of the pineal gland with the third ventricle. It is posterior to the third ventricle, right? And this one here is the lateral ventricle. This here is going to be the third ventricle. This is the thalamus in relation to the third ventricle, right? This is the sella turcica with the posterior pituitary showing the bright spot. This black is the sphenoid sinus here. Right? So these are the various structures that we should know here in the mid-sagittal section of the brain. Now going to the level of the basal ganglia, very, very important. So what do we have is frontal horns ke aaju-baaju we have the caudate ka head. Then these the lateral ventricles, they open into the third ventricle which will appear as slit-like midline structure. Adjacent to that will be the thalamus. Here we have the V-shaped internal capsule. Adjacent to that is the lentiform nucleus, and adjacent to that is this insular cortex. This is going to be the insular cortex. Have a look at this MRI. This is the frontal horn of the lateral ventricles. Uske aaju baaju mein caudate. This is the third ventricle, and adjacent to third ventricle is the thalamus, TH. This is the internal capsule, and here it is going to be the lentiform nucleus. This is the insular cortex, and this fissure here is the Sylvian fissure, which will have the branches of MCA running in that. Now look at the CT scan here. What are we seeing here? This is again the frontal horn, the caudate here, the third ventricle, the thalamus. This is where we will have the internal capsule, and then we will have the lentiform and the insular cortex. This is the choroid plexus calcification, and this is the acute hemorrhage. Look at how acute hemorrhage is appearing. Hyperdense on non-contrast CT. Right? So remember that investigation of choice for acute hemorrhage is CT scan. For chronic hemorrhage, it is MRI. Which sequence did we see? SWI. Okay, the SWI sequence. And in lentiform nucleus, remember that the medial and the lateral part, the medial is the globus pallidus, the lateral is the putamen. Okay, the lateral is the putamen. Now going to how do you identify in cross section whether we are at the level of midbrain, pons or medulla. Most important, this midbrain has this characteristic shape like this heart shape or Mickey Mouse shape. So when you see this classical shape, that is the midbrain. Behind that is the cerebellum vermis. Pons is the one which has the maximum diameter, the maximum thickness, and behind that is the fourth ventricle, and you have the cerebellum there. What is there in front of the pons? That's the basilar artery. And then we have, this is the lowermost one is the medulla. Adjacent to that are these two vertebral arteries. Okay, there are the vertebral arteries. You can see the maxillary sinus at this level. So that means we are at a down level, an inferior level. That is the level of medulla here. Okay, that's the level of medulla. So this is how you identify the brainstem structures. Now, look at this one. So why is it important to know anatomy is because when the anatomy is clear, you can localize the pathology and based on that, you can make a diagnosis. The best example here, look at this patient. This is the midbrain here, right? This is the aqueduct of Sylvius, the cavity of the midbrain. And in front of the midbrain, we have those mammillary bodies. Look at this midbrain and the mammillary body. The mammillary body is showing enhancement. So there is involvement of mammillary bodies. So whenever you have this history of an alcoholic patient with GOA features, GOA stands for global confusion, ophthalmoplegia, ataxia, that is going to be Wernicke's, and mammillary body involvement tells you that it is Wernicke's encephalopathy. Recent NEET PG question, Wernicke's mammillary bodies is involved. The periventricular area is involved. Even the thalamus can be involved. Mammillary bodies is very, very important. Now, next one, going to the vascular anatomy. Now, this is MR angio because I don't see the white bones. I see the vessels of both sides. So, this vessel here, this is the vertebral artery. The two vertebral artery, they fuse to form the basilar artery. So, number 3 is basilar artery. This is vertebral artery. And this basilar artery gives the terminal branch, which is the posterior cerebral artery. Okay, that's the posterior cerebral artery. Now, this is the internal carotid artery, which is the tortuous vessel supplying the brain. And look at the terminal branches, laterally going middle cerebral artery, anteriorly going anterior cerebral artery is what we are seeing there, right? And so this is basically the area of the circle of Willis that you can see. The PCA, the PCOM coming from ICA going to PCA. We have the internal carotid artery, we have the ACA and the ACOM. Remember that MCA is not a part of the circle of Willis. Now, next one, going to the pathologies, and before that, quickly telling you about the investigation of choice. So, remember that in brain, where do we use non-contrast CT? Non-contrast CT is the investigation of choice for head trauma, except for DAI, where MRI, the SWI sequence, is the investigation of choice. NCCT is used for calcification, right? Acute stroke, the first investigation is NCCT. Acute hemorrhage, it is going to be NCCT. Rest everywhere, we prefer doing MRI because it gives a very, very good resolution, the differentiation of gray matter, white matter. So, for brain pathologies, for spinal cord pathologies, we prefer MRI, right? So, example, if they ask you that in traumatic paraplegia, what is the investigation of choice? Paraplegia traumatic means spinal cord somewhere is involved, so we will do MRI in that case. So, any infective inflammatory space occupying lesion like meningitis, encephalitis, vestibular schwannoma, all these conditions we are going to do contrast enhanced MRI. Okay, so we'll do contrast MRI in these cases. Now, going to the pathology, CNS trauma and the various types of hemorrhage. So, first one that we see here, which has this biconvex shape, the idly shape, EDH has this biconvex shape. Remember, it does not cross the sutures, but it crosses the midline. And EDH is due to rupture of middle meningeal artery. EDH is the one which is associated with lucid. So, when I write lucid, remember the ED, it is associated with lucid interval. And in this EDH, when you see the hypodense areas, the black areas, that suggest the area of active bleeding, and that is called as swirl sign. So, when there is swirl sign, it indicates that active hemorrhage is going on and we need to do decompression. Surgery needs to be done. Next one is this crescent shape or the sickle shape. Remember, sickle shape, S for S is SDH. It is due to rupture of cortical bridging veins. Veins can be ruptured even with trivial trauma like a fall in alcoholic patient, or even in battered baby, we see the SDH. And the shape is the sickle or concavo-convex shape. It crosses the sutures, it does not cross the midline. And look at how the acute hemorrhages, they appear hyperdense on non-contrast CT. Chronic SDH, over a period of time, it will become less dense and it will start appearing gray, similar to CSF. So, remember that in EDH, the trauma is significant trauma because the MMA needs to be ruptured, the artery needs to be ruptured. Here, even trivial trauma, and here the history can be chronic as well, like in the recent NEET PG exam, 2 weeks ka history is more towards SDH. So remember, the clinical history is also important in making a diagnosis. Next is the subarachnoid hemorrhage. Subarachnoid space contains the CSF. So now instead of CSF, we would see blood in those spaces. So that is subarachnoid hemorrhage. The clinical manifestation is the thunderclap headache or the worst headache of life. What is the most common cause? The most common cause is trauma. But what is the most common non-traumatic cause? It is berry aneurysm rupture. Now, so what do we see here is all these cisterns, the interhemispheric, the lateral fissure, the perimesencephalic, all these are containing the white blood. Normally, they should contain CSF. So, this is the subarachnoid hemorrhage. This central cistern there, the suprasellar cistern has this pentagon or star shape. This is called as star of death. When there's hemorrhage there, star of death. Next one, what do we have here is this intraparenchymal hemorrhage. This is intraparenchymal within the parenchyma, and for intraparenchymal hemorrhage, the most common cause is hypertension. The most common site is putamen, and so putaminal bleed, we should think of hypertensive bleed. So acute hemorrhage, non-contrast CT, chronic hemorrhage is SWI MRI. In MRI, we can also do the dating of the hemorrhage, whether it is acute, subacute, chronic, based on its appearance on T1 and T2. So remember that it is the subacute hemorrhage which appears T1 bright. So T1 may what appears bright is this subacute hemorrhage because of the presence of methemoglobin. So remember, it is subacute hemorrhage which appears T1 bright. Now going to next one, what do you see in this image here? This investigation is DSA. The black vessels tell me that this is DSA. And what are we seeing here is the blob of contrast here tells you that this is an aneurysm. This is the internal carotid artery which is giving MCA and ACA. So this is ACA aneurysm. And look at the blood in the interhemispheric fissure. So the localization of the subarachnoid hemorrhage can tell us that which artery is most likely which has ruptured, which artery aneurysm has ruptured. Also look at subarachnoid hemorrhage going into these sulcal spaces, the sylvian fissures. It can have the intraventricular extension as well, right? So this is ACA aneurysm with interhemispheric, the sylvian fissure and the intraventricular bleed is what we are seeing here. So remember that in subarachnoid hemorrhage, the first investigation will be non-contrast CT to look for the hemorrhage, and then it would be CT angio to look for where the aneurysm has ruptured. Are there any other aneurysms which can rupture? All that we need to see, and we do CT angio for that. The gold standard investigation would be DSA because it is invasive and it is therapeutic as well. Now this one, hemorrhages in the brain, right? In a patient of RTA who has poor GCS or worsening GCS but the CT scan appears normal. And in that case, what you should think of, it is diffuse axonal injury. In diffuse axonal injury, the investigation of choice is MRI SWI to look for those punctate hemorrhages which appear as this black areas of blooming. It can involve the corpus callosum, it can involve the brainstem. So we have Adams grading for diffuse axonal injury. Grade 1 is when we have the hemorrhage at the gray matter, white matter interface. Grade 2 is towards corpus callosum, and grade 3 is the involvement of the brainstem which has the most poor prognosis, right? So this is diffuse axonal injury. Classical history is what we would get. Next, what is this sign in a patient of trauma? So this is the mountain dessa appearance. This is called as Mount Fuji sign, which is suggestive of tension pneumocephalus. You can see that it is black color air. So this is Mount Fuji sign in tension pneumocephalus. Now going to the imaging in stroke. The first investigation in stroke would be non-contrast CT because the first thing that we have to do is differentiate whether the stroke is the ischemic stroke or a hemorrhagic stroke. Why? Because the management will depend on that. If it's a hemorrhagic stroke, we will not do thrombolysis, right? And a CT scan can very well help us in differentiating the two. If it is hemorrhagic, it would be hyperdense, right? If it is ischemic, CT scan can be normal or it can show the hypodense infarct. But at least if it is hemorrhagic, it will show the hemorrhage, and we know that we don't need to thrombolyze there. So what is the most sensitive investigation for ischemic stroke? Remember that in the early infarct phases, the CT scan can be normal. So that is why the most sensitive is MRI and the sequence is diffusion weighted imaging. Acute infarct gives restricted diffusion. Okay, it gives restricted diffusion. What is the investigation to look for the penumbra? Now, penumbra is that ischemic area surrounding the infarcted core, which is salvageable, and we can identify that on CT perfusion or MR perfusion. CT perfusion helps in that. So, this is the stroke imaging algorithm. First is the non-contrast CT, hemorrhagic है, ischemic है. उसके बाद we do CT angio, basically to look for proximal vessel occlusion. Because if it's a large vessel which is occluded, we know that we can give intra-arterial therapy. We can go inside that large artery and give the intra-arterial therapy. Then we go for a DWI and we decide whether intra-arterial therapy can be done. CT perfusion helps in evaluating the ischemic penumbra region, right? So remember, the role of CT angio is to evaluate the proximal vessel occlusion. So look at the various strokes. What can we see on CT? If it is hyperdense, remember the fresh RBCs in acute hemorrhage, they give a hyperdense appearance. So this is hemorrhagic stroke, right? Hypertension, most common cause, basal ganglia putamen, most common site. So hemorrhage is hyperdense. Infarct is like this. It's a well-defined hypodense area with the loss of grey matter, white matter differentiation and in a well-defined vascular territory. Like in this case, this is the territory of the left middle cerebral artery, right? This is the territory of ACA, Piche will be PCA. So this patient of left MCA infarct clinically would have presented with right hemiplegia, the opposite side hemiplegia. What are we seeing in this image here? This is the third ventricle, this is the thalamus and this is the hypodensity there. So a small infarct like that is called as lacunar stroke, appearing like a lacuna, a small hole. So this is a lacunar stroke, which is because of the lenticulostriate branches of MCA, the small lenticulostriate branches that gives the lacunar stroke. Now, what are the various signs in acute infarct in CT or on DWI? So, first one here is the hyperdense MCA sign or any hyperdense vessel sign. So, like you see here, this is the location of the middle cerebral artery going laterally. This is a non-contrast CT. The vessel should not appear white. Here the vessel is appearing white, so abnormal. The vessel is appearing white because of the dense thrombus within. It is because of the dense thrombus, so hyperdense MCA sign indicates the thrombus in the MCA. This can be the first sign that we might see without the parenchymal changes in the CT brain. Next one is the insular ribbon sign. Okay, the next one is the insular ribbon sign. So look at this insula. And look at this insula here. Because of the insular involvement in an infarct, the insula becomes hypodense and the normal insular ribbon which appears, the insular cortex is lost. So that is actually the loss of insular ribbon sign suggestive of MCA infarct. This is a DWI MRI where you see this area appearing very bright like a light bulb. So remember that this is the light bulb sign on DWI. This will be seen with acute infarct. So on DWI, the acute infarct appears bright. On ADC, it appears dark. Okay, on ADC, it appears dark. So these are the various signs in acute infarct. Now, if you have a patient with recurrent TIA and you see this on angiogram, this is a DSA, the black vessel again. What do we see here? The black is the contrast which has gone outside the blood vessels like a puff of smoke. So this is the sign which is the puff of smoke appearance which is seen in Moya disease, right? This is seen in Moya. What is Moya? It is the internal carotid artery stenosis leading to decreased blood supply to brain, formation of collaterals, and these collaterals, they leak out the contrast. So that gives the puff of smoke appearance in Moya. Right, remember Moya is also associated with neurofibromatosis. Now coming to the venous obstruction, that is dural venous sinus thrombosis, the investigation of choice is MR venogram. And what do you see here? The empty delta sign which is seen on contrast enhanced CT, not on the non-contrast CT. So when the dural venous sinus is blocked, because the contrast cannot go inside because of the thrombus, it appears empty. So empty indicates the filling defect. Why is it empty? Because there's thrombus, so filling defect. Delta is the triangular appearance. So look at the triangular appearance of the superior sagittal sinus. So this is seen in superior sagittal sinus thrombosis on contrast enhanced CT. When it's MRI, on MRI the obstructed vessel shows the absent flow void. Normal patent vessel, the flow void is present. It is a void absent signal due to the flowing blood. When the blood becomes stagnant, that is thrombus, then it gives a signal. So that is the absence of flow void is suggestive of thrombosis. Now that was empty delta sign. Where do you see the empty theta sign? A previously asked question. So theta is in the spinal cord, that sac containing the CSF and the nerves. So when there is arachnoiditis, this is seen in arachnoiditis. The inflammation of the arachnoid causes the clumping of the nerve roots. So what happens is this thecal sac appears empty, only CSF, no nerves. Normally in the CSF, this thecal sac, you should see those nerve roots. You are not seeing here, this is empty thecal sac sign because of the clumping of the nerve roots that has happened because of the arachnoiditis. So remember, empty theca sign is arachnoiditis. Okay, that is arachnoiditis. What do you see in raised ICT? So in raised ICT, in a child, the first sign is sutural diastasis. We are talking about the radiological sign. In child, the sutures are open, so the pressure will vent out and it will cause sutural diastasis. In an adult, the sutures are closed, so not sutural diastasis, but it is the erosion of the dorsum sellae or the clinoid process. So that is what we see in an adult. What is this appearance in raised ICT? This is like a copper sheet which is beaten with a hammer. So imagine the raised ICT beating on the skull, that is giving this copper beaten appearance of the skull. This is also called as silver beaten or bronze beaten. So any beating basically giving this prominent markings on the skull. This is a feature of raised ICT. Okay, this is a feature of raised ICT. Now the next that we are going to see are the important neurocutaneous syndromes and the radiology correlation. This topic has been covered in detail in the main videos. Here we would be focusing on the most important and the most frequently asked points. So the first one that we have here, now what do we see in this first image is along the ependyma, that is the ventricle lining, there are these calcified nodules. So calcified subependymal nodules, these are features of which neurocutaneous syndrome? Tuberous sclerosis. So remember tubers are seen, hematomas are seen. Sclerosis, you can remember sclerosis like calcification. So calcified tubers, calcified subependymal nodules. One of these non-calcified subependymal nodules can enlarge and it can form a tumor. So what brain tumor we see in tuberous sclerosis? SEGA, subependymal giant cell astrocytoma. What is the most common site for that? It's the foramen of Monro. So remember, tuberous sclerosis is SEGA. In tuberous sclerosis, heart has cardiac rhabdomyomas, kidneys have AML cyst, RCCs, pancreatic cyst, lamb in the lung. All these are the features that we see. Next one, when we have these tumors here, the pons and the cerebellum ke angle mein, that is the cerebellopontine angle tumors bilaterally, showing this ice cream cone appearance, the ice cream cone appearance. So this is suggestive of vestibular schwannomas. So bilateral vestibular schwannomas are hallmark of NF2. Remember, bilateral is 2, it is NF2. The chromosome number is also 22, chromosome number 22. And along with that in NF2, we can have other tumors as well. The MISME, multiple intracranial schwannomas, meningiomas, ependymomas is what we see. So we have optic nerve meningioma in NF2. While in NF1, we have optic nerve glioma. Okay, optic nerve glioma. Another one where you see the cerebellar lesion, which is having this cystic lesion with the enhancing mural nodule. This is suggestive of hemangioblastoma, and hemangioblastoma is seen with, it is associated with VHL, right? Von Hippel-Lindau syndrome. Cystic lesion with enhancing mural nodule, the DD is also pilocytic astrocytoma, but in that case, it would be a child. Here in hemangioblastoma, generally it's an adult. Next one, what do we see here is, this is the white calcification following the gyri. So the gyriform calcification or the tram track calcification, that is the hallmark of Sturge-Weber syndrome. So remember Sturge-Weber SS, there is port wine stain with seizures and it is sporadic. It is not like inherited, and it can cause cortical atrophy of that side. Hemicortical atrophy is what we can see. Like you see that this cortex is small as compared to the other cortex. So remember, tram track calcification is Sturge-Weber syndrome. Now, that was tram track calcification. Tell me the other calcification here. What is the other type of calcification that you can see in brain? Previously asked, this is the bracket calcification, right? This is like a bracket. So this is bracket calcification. Where do we see bracket calcification? ये midline lesion है, dark lipoma. So midline dark, it is corpus callosum. Lipoma shows bracket calcification. Where do we see popcorn calcification in the brain? Cavernoma. Okay, cavernoma. These are the various calcifications. Next, we saw corpus callosum lipoma. What do you see in corpus callosum agenesis? So remember, corpus callosum agenesis has the racing car sign. RAC is the mnemonic. Remember, R for racing car is seen in agenesis of corpus callosum. Racing is seen in agenesis of corpus callosum. What is a racing car like? Racing car has the back wheels larger as compared to the front wheels. So here what happens, the posterior horn of lateral ventricles becomes more dilated. That is called as colpocephaly. And the lateral ventricles can have this parallel arrangement. So this is feature of corpus callosum agenesis. So this is racing car lateral ventricles. Where do you see boxcar lateral ventricles? So remember that boxcar is seen in Huntington's disease, Huntington's chorea. So what are the features? Clinical features are the 3 M's. Abnormal movement, there is chorea. Mood abnormality, irritable, aggressive patient. And memory affected, there is dementia. So in Huntington's chorea, which basal ganglia is gone? Remember, C for C. It is caudate atrophy. Going back to anatomy, caudate is located adjacent to the frontal horn. So when the caudate atrophies, the frontal horn gets dilated. So now it is the front wheel getting dilated. So the dilatation of the frontal horns as compared to the posterior horns, that is called as boxcar ventricle. Boxcar ventricle, Huntington's disease. So normal frontal horns are pinched. When they get dilated like this, then it is the boxcar ventricle. Coming to some other important signs in neuroradiology, because we saw the racing car, the boxcar, let's complete the other signs here. So first one, the eye of tiger sign. What part of the brain is this? This is the globus pallidus, putamen ke andar, showing this eye of tiger sign. Remember, tiger, scary, scary is Halloween. So Halloween, that is Hallow-Warden's disease, shows this eye of tiger sign in the globus pallidus. Next one, PSP, progressive supranuclear palsy, which has the history of frequent falls, vertical gaze palsy. It shows this bird wala sign, which is humming bird sign. So remember, bird goes supra, upper, the bird flies supra. So supranuclear palsy is hummingbird sign, which is because of this midbrain atrophy in PSP, right? So that gives the hummingbird sign. Next, we have this face of giant panda sign. Who has a face like giant panda? Wilson. So remember, Wilson has face of giant panda or mini panda or double panda, whatever panda it is Wilson's. Face of giant panda we see here in the midbrain. This is the face of giant panda sign, Wilson's. And the eye shows the KF ring, right? Very, very important. Serum ceruloplasmin is what we test for. It is decreased, urine copper is increased. Gold standard is the liver biopsy. This one is the hot cross bun sign, which is affecting the pons. Okay, this is the pons, Piche fourth ventricle cerebellum. So the hot cross bun sign is a feature of multi-system atrophy. MSA, especially the cerebellar type, shows this hot cross bun sign in the pons. Right. Now going to infections. Right. Infections in the brain. Now what are we seeing here is these conglomerate lesions with the ring enhancing pattern. There is this hydrocephalus. There are these basal exudates, the thick meningeal enhancement, that is features of meningitis. So all these put together along with this lipid peak at around 1.3 ppm on MR spectroscopy, that is before NAA, that is the lipid peak. All these are features of TB. Okay, all these are features of TB. So conglomerate ring enhancing lesions, hydrocephalus, because it causes that communicating hydrocephalus. meningitis. It can also cause infarcts because of the blockage of the small arteries, and lipid peak. All these are features of TB. Next, what is this? When you have a cystic lesion with a dot within, cyst with dot, it's a cyst, that is neurocysticercosis. Neurocyst with the cercosis, that is the scolex within. These are the multiple neurocysticercosis. So NCC, the common site is the gray matter, white matter interface is where it can involve. And in the late stages, the final stages, it gets calcified, indicating the dead parasite. So the white calcification gives the starry sky appearance. Okay, that gives the starry sky appearance. Similarly, cysticercosis in the muscle, it can cause this rice grain calcification. Even this is a feature of cysticercosis, tinea solium, right? It is basically tinea solium. So this is NCC. Now, where else do you see the starry sky? In the brain, NCC. Hematology, Burkitt's lymphoma. Remember Burkitt stars in the sky. Acute viral hepatitis, the liver appearance on ultrasound. And on immunofluorescence, it is post-streptococcal glomerulonephritis. What are the other infections? What do we see here? Surrounding the ventricle is the calcification, the calcification, the calcification. So what are we seeing here is periventricular calcification, which is a feature of CMV, recent NEET PG question. So remember CMV, V is the ventricle calcification. And other important points here, it can also cause SNHL. You have the owl's eye appearance with CMV. When you have a patient with encephalitis involving the temporal lobe, this is the temporal lobe surrounding the midbrain, the basifrontal lobe. Temporal lobe involvement, we should always think of herpes simplex virus encephalitis. Again, a recent NEET PG question, HSV encephalitis. When you have bilateral thalami involved in a patient of encephalitis, think of Japanese encephalitis. Okay, Japanese encephalitis, bilateral thalami involved. Now, in a HIV positive patient, the various infections, the opportunistic infections, bilateral basal ganglia involved, with this ring enhancing lesions with eccentric target sign. Within the ring enhancing, there is eccentric target. So remember target sign T for T, this is toxoplasma. Toxoplasma. When you have the soap bubble appearance, the white gelatinous material in the enlarged VR spaces, this is suggestive of cryptococcosis. Cryptococcosis. And when you have this periventricular lesion which is enhancing, then you should think of lymphoma, which is associated with Epstein-Barr virus, right? So this is a lymphoma. So important infections here. Now going to the demyelinating lesions, multiple sclerosis, then you have NMO, neuromyelitis optica. So multiple sclerosis, what criteria do we use for diagnosis? It is McDonald's criteria, which talks about dissemination in space and dissemination in time of the lesions. So what is the investigation of choice here for multiple sclerosis? It is contrast enhanced MRI. Contrast helps us identify whether the lesion is acute or it was chronic wala. Acute recent lesions will enhance, chronic will not enhance. So it helps in identifying the dissemination in time. And MRI in multiple sclerosis will show the abnormality in the white matter because it's a demyelinating lesion. Myelin is the white matter, right? And what do we see is this Dawson's fingers, the classical appearance here, Dawson's fingers. So ventricle ke perpendicular, we see those demyelinating plaques like the fingers, that is the Dawson's fingers. Axial lesion has this demyelinating plaques, that is the multiple sclerosis. Now, how do we differentiate it with NMO? Radiologically, in the spinal cord, if more than 3 vertebral levels are involved, it's a long segment involvement, then it is NMO. So remember NMO, 3 letters, more than 3 levels involved. What antibody do we have here? Aquaporin 4 antibody. Next, if you have this patient, an alcoholic patient with rapid correction of hyponatremia, so you know that it is osmotic demyelination syndrome. The sodium causing the osmotic demyelination. Previously, it was called as central pontine myelinolysis. So, in the pons is where we see the myelinolysis. So, what do we see is this appearance in the pons. What is this appearance called as? This is the trident sign or the piglet sign. So like a trident, this is a trident sign suggestive of central pontine myelinolysis. Now it is called as osmotic demyelination syndrome. Now going to various leukodystrophies. Which is that leukodystrophy which has this tigroid appearance like this? The black lines in those white areas, that is metachromatic leukodystrophy, MLD, which has the deficiency of aryl sulfatase A, right? Aryl sulfatase A. Now, how do you differentiate Alexander's from X-linked adrenoleukodystrophy from Canavans? So remember alphabetically. When I say A, B, C, D, A comes in the front. So Alexander's involves the frontal lobes predominantly. X comes behind. So posterior is X-linked. Canavan, C for continuous white matter, entire white matter is involved. So when it is anterior involvement like this, the hyperintense white matter is abnormal. Anterior in the front, frontal lobes, Alexander's, right, Alexander's. Posterior involving the splenium, the peritrigonal white matter. Posterior Piche alphabet is the X-linked adrenoleukodystrophy. And when it is diffuse, you can see the entire white matter is white. Continuous diffuse is Canavans. It is Canavans. And Canavans classically has this increased NAA peak. So remember Canavans, when I write Canavans, the NAA helps me to remember the increased NAA peak is a feature of Canavans disease. Next one, coming to vascular malformations. So classical history, if you have a newborn with congestive cardiac failure, hydrocephalus, the combination of these features, straightforward, the diagnosis becomes vein of Galen malformation. So remember that many times in image-based questions, it's just the history which is enough to make a diagnosis. So vein of Galen actually is a misnomer. It is a precursor of the vein of Galen, the prosencephalic vein, which is present there, the embryonic precursor which is present, and it becomes prominent because of the multiple drainage of the AV malformations there. And what you will see classically is, in the sagittal image, in the midline, below the corpus callosum will be this dilated vessel. So look at this. This is the dilated vessel. This is the enhancing dilated vessel below the corpus callosum. That would be the classical finding in vein of Galen. Next one, when you have this bag of worms appearance, which is because of the prominent flow voids, and we have this nidus on DSA, then it is suggestive of AV malformation. Okay, then it is suggestive of AV malformation. So AV malformation has this abnormal entangled vessels, the nidus with the bag of worms. This can rupture and this can lead to hemorrhage in unusual locations. So when the hemorrhage is in basal ganglia, we think of hypertensive. Other locations, young patient, we should keep AV malformation in mind in the differential diagnosis. This vascular malformation which has this popcorn appearance with the hypo-intense rim surrounding it. So popcorn appearance with the hypo-intense rim, this is classical of cavernous angioma or cavernoma. This one, when you have a patient with history of trauma in the past, now presenting with pulsatile proptosis, think of carotico-cavernous fistula, which can occur post-trauma. So what happens with carotico-cavernous fistula, the communication between carotid artery and the cavernous sinus, the cavernous sinus gets bulky because of the increased pressure coming from carotid. Because of that, the superior ophthalmic vein draining into cavernous sinus gets enlarged. So the feature here is going to be enlarged superior ophthalmic vein, like you are seeing here in the eye. The superior ophthalmic vein is enlarged. This is a DSA showing the carotid artery and the fistula with the cavernous sinus, right? So there is going to be a direct communication without a nidus in AV fistula. Nidus is a feature of AV malformation. So for these vascular malformations, like DSA is the gold standard. Now going to next topic, that is brain tumors. Okay, coming to brain tumors. So for brain tumors, it is contrast enhanced MRI, which is the investigation of choice. MR spectroscopy can help by showing the choline peak. We can do MR perfusion to look for the increased vascularity, and even to differentiate radiation necrosis versus recurrence. Right, so let's say a patient of brain tumor has undergone radiation. Now we are doing MRI. We are not sure whether this is necrosis or this is recurrence. The various investigations that can help is, one is MR perfusion. If it's a tumor, increased vascularity, necrosis, no vascularity. Second is PET scan, tumor will have increased uptake, necrosis is dead, no uptake. And the gold standard, of course, is going to be biopsy. The gold standard will be biopsy. So coming to individual brain tumors here, first one, which has this dural tail sign. Remember, dura is meninges, meninges is meningioma. So dural tail sign is a feature of meningioma, though not specific, but for our exam, let's remember meningioma. Look at the enhancement of the tumor. It's a homogeneously enhancing tumor. It's an extra-axial lesion. It is outside the brain parenchyma, meninges. Common age group, it's a young adult female because this is progesterone receptor positive. It shows hyperostosis, not the osteolysis of the adjacent bone. It's a slow-growing tumor causing bony sclerosis. Mother-in-law sign, the mother-in-law is a contrast pattern enhancement. Comes in early like mother-in-law, but stays there for long. So basically, there is early wash-in with delayed wash-out. Early wash-in with delayed wash-out. And then on angiography, there's a spoke wheel sign, the main vessel coming in the center, and from there, it is showing this spoke wheel sign on angiography. Histopathologically, it shows psammoma bodies. Remember, meningioma shows psammoma bodies. Next one, when you have a brain tumor, which appears necrotic and it has this nodular enhancement. This is suggestive of a high-grade tumor like GBM, glioblastoma multiforme, which is an aggressive grade 4 WHO tumor. And this GBM can cross the midline, involve the corpus callosum, and then it can give this butterfly appearance, that is butterfly glioma. Okay, so this is GBM. Next one, ependymoma versus medulloblastoma. Both of these, they commonly occur in the posterior fossa. The difference is ependymoma E के बाद आता है F. Remember, it's related to the floor of the fourth ventricle. Medulloblastoma is related to the roof of the fourth ventricle. E के बाद आता है F. Remember, ependymoma also has foraminal extension. It's a toothpaste-like tumor. So look at this tumor here, which is going into the foramen magnum. Look at this tumor going into the various foramina, right? Like the foramen of Luschka here. Foraminal extension floor is the ependymoma. Medulloblastoma is a hypercellular tumor. Hypercellular means increased density, so it appears hyperdense on CT. Hypercellular shows restricted diffusion, right? So remember, these are the features, and both of these can show drop metastasis. So we give prophylactic craniospinal irradiation. Next one, when you have a child with the cystic lesion with enhancing mural nodule, we spoke about that, the tumor we think of, pilocytic astrocytoma, right? In the cerebellum, this cystic lesion with enhancing mural nodule. When you have a tumor with cortical calcification, a cortical tumor with calcification, then you think of oligodendroglioma. Remember, oligo, O like an egg. It gives the fried egg appearance on histopath, oligodendroglioma. Next one, pituitary tumors, craniopharyngioma and pituitary adenoma. The difference is adenoma arises from the pituitary itself. Craniopharyngioma, the rat case cleft remnants, it is predominantly suprasellar and it can come into the pituitary. So the pituitary adenoma, when it grows out, macroadenoma, that is what gives the figure of 8 appearance. So it will cause the sella widening because it's growing in the sella, and then it is going out with the constriction. So that gives the figure of 8 appearance in pituitary. Macroadenoma, because microadenoma will be small within the pituitary itself. On the other hand, when you have the CC and C, that is a midline lesion with calcification, cystic areas in a child, then you think of craniopharyngioma. So midline lesion with calcification, cystic areas, it is craniopharyngioma. Pituitary lesions give what visual field defect? Remember, it is bitemporal hemianopia because it compresses the optic chiasma. When the optic chiasma is compressed, then it is bitemporal hemianopia. Now, coming to epidermoid cyst, a previously asked question in one of the AIIMS exam, how do you differentiate it from arachnoid cyst? So epidermoid cyst, because it contains a thick keratin-like material, it shows restricted diffusion. It is not containing water, so it is not suppressed on flare. versus arachnoid cyst, which is CSF containing. It is suppressed. It does not show restricted diffusion. So look at this cystic lesion here in the CP angle, which is not completely suppressed on flare and which shows restricted diffusion. So DWI and flare sequences can help us to differentiate epidermoid cyst from arachnoid cyst. Now coming to congenital malformations. First one, the posterior fossa malformations. When the posterior fossa is small, it is Arnold-Chiari malformation. Large posterior fossa, Dandy-Walker malformation. In Arnold-Chiari, so because of the small posterior fossa, the posterior fossa contents go down. So what do you see is this herniation of the cerebellar tonsil. This is called as peg-like tonsils. This is the feature of Arnold-Chiari 1. In Arnold-Chiari 2, along with that, the brainstem also goes down and we have meningomyelocele is associated with Arnold-Chiari type 2. Arnold-Chiari type 3, remember 3 ka ulta is E. We have encephalocele associated in Arnold-Chiari type 3. What else do we see in Arnold-Chiari type 1 is this prominent central canal in the spinal cord, which is called as syrinx or syringomyelia. In Dandy-Walker, the large posterior fossa, because of this large posterior fossa cyst communicating with the fourth ventricle, so this gives this appearance which is called as the keyhole appearance. It gives the keyhole appearance. There is absent cerebellar vermis in Dandy-Walker malformation. Right, so that gives this keyhole appearance. Along with that, there are other features like corpus callosum agenesis. All those features are seen. The next congenital malformations, when you see that the brain surface is completely smooth, there are no gyri, no sulci, it's a smooth surface. Smooth is lissencephaly. Right, this is lissencephaly and that gives the appearance of the brain which is figure of 8 appearance. So it is just a small sylvian fissure which is present. Figure of 8 appearance. When you see that the brain is like just one complete brain, there's no midline division, falx is absent. There is this one monoventricle which is horseshoe shaped monoventricle. Then you think of holoprosencephaly. Holo, the brain is like one complete brain, there's no division. Holoprosencephaly, that is called as pancake brain. When you have this cleft in the brain, which is containing the CSF, it might or it might not contain the CSF. Cleft is basically a split and split is schizo, like ski is split. So this is called as schizencephaly. Okay, this is called as schizencephaly, the split with the CSF containing. Now when you have this molar tooth appearance of the midbrain because of the elongated cerebellar peduncles, the bat wing appearance of the fourth ventricle, then what is the diagnosis? Then this becomes Joubert syndrome. So molar tooth with bat wing fourth ventricle is the Joubert syndrome. Where did we see bat wing in the chest x-ray? Pulmonary edema. Okay, that was pulmonary edema.
So friends, now we are going to learn about the head and neck radiology, basically integrating radiology with ENT and the ophthalmology part. Somehow in the recent years, we have seen that a lot of images and questions are being asked from this aspect of integration of ENT, ophthalm and radiology. So first one, let's talk about the X-ray views. Many questions in the recent years. So what X-ray view do we have for maxillary sinus, for frontal sinus, for superior orbital fissure and all of those? So let's learn this with this easy trick and an interesting story mnemonic. So imagine that there is a place there and that place is a hilly place. And the main town where all the activities are there, the park is there, the shopping area is there, the main town is located down, inferior. So remember that town is down, that means inferior. So town is the townie's view which is done for inferior orbital fissure. Superiorly in that area are located the hills and on the hills are the houses of the native people there. And in front of each house there is a well. So remember, well is located superior and well is in front of the house. So well is the card well view which is located in front of the house and superior, that is the superior orbital fissure and frontal sinus. We have card well view for that. Now then we have this girl here wearing maxi and she is drinking water. So maxi is maxillary sinus and it is the water's view. Now you can see that when this girl is drinking water, it is touching the floor of the orbit. The glass is touching the floor of orbit. So water's view is also for the floor of the orbit, and it is touching the nose and the chin. So water's view, when we do, the patient is asked to touch the nose and the chin on the cassette. So it is nose-chin position or occipitomental view. The X-ray beam comes from behind, goes to the mental area covering the maxillary sinus. And who is watching this girl through this binoculars ka foramen? This guy's name is Rees. So remember that Rees sees through the foramen. That means this is for the optic foramen. This X-ray view is basically for the optic foramen or optic canal. We have the Rees view. So completing the list here, what do we have is for maxillary sinus, maxi is water. Frontal in front is well, that means it is Cardwell view. Pierre's view is basically the name for open mouth waters view. So when we do waters view with the open mouth, it is called Pierre's view. And the advantage is it helps us in the visualization of the sphenoid sinus also. Otherwise, for dedicated sphenoid sinus, we can use the submento vertical view or the basal view. Through the base of the skull, we will see the sphenoid sinus. Superior orbital fissure, superior is the well, so that is the Cardwell view. Inferior orbital fissure, down is town, so that is Townie's view. Through the foramen sees Rees, so optic foramen or optic canal is the Rees's view. So that is about the X-ray views here. Now identifying the images, what X-ray view are we doing here? The chin touching the cassette, nose-chin position, that is the Waters view, occipitomental view done for maxillary sinus. It can be closed mouth or it can be open mouth like this, which helps in the visualization of the sphenoid sinus, that is Pierre's view. And look at the normal sinuses, they should be black, containing air. But when they are opacified, it suggests sinusitis. But what is the investigation of choice for paranasal sinuses? More sensitive than X-ray, of course, is the HRCT, paranasal sinuses, which a lot of anatomy is seen well in the coronal section, right? In the coronal section. This X-ray view is the nose and the forehead position, and it is occipitofrontal view, occipitofrontal view. So in the forehead, we have the frontal sinus. So basically, this is the Cardwell view, which is done for frontal sinus. How do we identify Cardwell view? Asked in a recent exam. So in the Cardwell view, you would see the frontal sinus well. The maxillary sinus will not be seen well, unlike the Waters view. There would be this bone overlapping the maxillary sinus. Frontal sinus would be seen well. Okay. Now coming to the normal anatomy on CT-PNS, most important here. So look at this one. This is the maxillary sinus, the anterior aspect. We have the nasal septum here, inferior turbinate, which is the independent bone there, right? Look at this one here. So we have maxillary sinus, the inferior turbinate, and then this bone here. What is this bone? The projection here. This is the uncinate process. Okay, this is the uncinate process. Inferior turbinate, above that is the middle turbinate that we are seeing here. And this area is the OMU, the osteomeatal unit, which drains a lot of sinuses, right? Now, look at this one. What is happening to the middle turbinate here? In the middle turbinate, you can see that it is expanded with black air. That means it is pneumatized middle turbinate. So, pneumatized middle turbinate, the term used for that, it is called as concha bullosa. Right? Concha is the turbinate. Bulla matlab it has expanded by the air. So, concha bullosa is pneumatized middle turbinate. In one of the INICT exam, this image was asked. This is inferior turbinate, middle turbinate, and then it is the superior turbinate. So, this is the pneumatized superior turbinate, not the middle turbinate. So, you should be able to identify the turbinates there. Some variations in the paranasal sinus anatomy, the important cells that we need to know. Which is that cell which is related to this optic nerve? The cell related optic nerve ON is ON optic nerve Onodi cell. It is the posterior most ethmoid cell. The infraorbital cell, anterior ethmoid cell, that is called as Haller cell. So, Haller cell is infraorbital. The one which you see here, the anterior most, we are still at the level of the nose. Maxillary sinus is just beginning to see. So, anterior most, sabse aage is the agar nasi cell, which is the anterior most ethmoid cell. you can see that this frontal sinus draining into the frontal recess, the cell in front of that is called as the agar nasi cell. In front of the frontal recess, that is sabse aage agar nasi cell. Now coming to the pathologies in the paranasal sinuses, most important, what do you see here? The expanded sinuses with the hyperdense contents. Remember, we saw the same thing in ABPA in CD chest, the hyperdense mucus in the bronchi. That is the ham sign. Similarly, here the hyperdense fungal contents. So this is allergic fungal sinusitis. Allergic fungal sinusitis, which gives this double density sign. The mucus and the hyperdense fungal elements, that is the double density sign. Next, what do we see here with mucormycosis, which we saw with the COVID-19 diabetic patients on steroids, right? So the mucormycosis, the black fungus caused this black turbinate sign. The turbinate is not enhancing because of the necrosis. What are we seeing here? The maxillary sinus is opacified with a mass, and the mass is going into the choana, the posterior nasal opening. So antrochoanal polyp is what we are seeing here. Okay, that is the antrochoanal polyp. Remember one sign which can help us differentiate from the nasopharyngeal mass, that is a Dodd sign. Okay, so when the antrochoanal polyp goes into nasopharynx, there will be that a line of separation between the polyp and the nasopharynx wall. Right, so that is the Dodd sign. What are we seeing here in the maxillary sinus? This is the mucus retention cyst. Okay, that's the mucus retention cyst. Recent NEET PG exam, the question here, a patient with history of trauma, now having proptosis, and there is a mass expanding the frontal sinus. So you can see that this is normal air containing. This is the expanded frontal sinus. The expanded frontal sinus with hyperintense contents, it can cause proptosis. This is frontal mucocele. Okay, this is frontal mucocele. It will not enhance. Right, so this is frontal mucocele. Now going to the trauma wale images, very important. What do we see here? From the floor of the orbit, there is something protruding out. This is called as teardrop sign. So basically, this is seen with blowout fracture of the orbit. That is the fracture floor of the orbit. So when there is a fracture here, the content herniating down, the fat and sometimes the inferior rectal muscle going out through the defect, that is the teardrop sign. This one here, what is this investigation here? You are seeing the contrast in the CSF containing spaces. This is CT cisternogram, which is done for CSF leak. So post-trauma, patient comes with continuous rhinorrhea, right? The target sign is positive, and we do CT cisternogram to look for the site of the leak. So CT cisternogram is done for CSF leak. Now going to the tumors. What sign are we seeing here? So look at this maxillary sinus. Look at this maxillary sinus. The posterior wall, there is bowing of the posterior wall because of the mass here. So this bowing of the posterior wall of maxillary sinus, this is called as Holman's Miller sign. And this is seen in nasopharyngeal angiofibroma, which classically is an adolescent male with recurrent epistaxis. So this is nasopharyngeal angiofibroma, the Holman-Miller sign. What investigation is this? The black vessel, this is DSA. This is the carotid artery. You can see the splaying of the ICA and the ECA. Right, they are splayed because there is this tumor blush that you can see here, the tumor at the bifurcation, that is the carotid body tumor chemodectoma, causing the widening at the branching of the carotid, that is called as Lyer's sign. Okay, that's the Lyer's sign in carotid body tumor. Now going to CSOM and its complications. So look at this image here. You see that the mastoid bone here is sclerosed. There is destruction. And look at this. What do we see is, this is the cerebellum. There is a ring enhancing lesion. So the complication that has occurred here is cerebellar abscess, right? Similarly, what do you see here? This is not cerebellar abscess, a previous NEET PG question. This area is the temporal lobe. You can see the temporal horn of the lateral ventricle here. So this is temporal lobe. This image is showing temporal abscess, right? This is temporal abscess. CSOM can also lead to thrombosis. The sigmoid sinus thrombosis, lateral sinus thrombosis is another complication that it can lead to. In that case, we will see absence of flow void on MRI. Now coming to the next important signs, the thumb sign and the steeple sign. So this thumb sign here, look at the epiglottis appearing like a thumb because it is inflamed and thickened. So thumb sign is epiglottitis. It is the epiglottis like this appearing like a thumb. Steeple sign is seen in croup, that is laryngotracheobronchitis. Because of the inflammation, there is narrowing which is happening in the lumen. So that narrow pointed lumen, that is called as steeple sign. Again, a recent NEET PG question asked many times previously as well. Next, what do you see here is that prevertebral soft tissue is increased. It is widened. So widening of the prevertebral soft tissue, the criteria is at the C2 level, it should be more than 7 mm. At C7 level, it should be more than 22. So 2 by 7 and 7 by 22. 2, 7, 7, 22. Then it is retropharyngeal abscess. Okay, pharynx ke piche. So retropharyngeal abscess, you can see some air foci also there. Next one, a recent FMG exam question where we had a trumpet blower with a neck swelling. And when you do CT, you see that it's communicating with the larynx and it is air-filled. Black is air-filled. This is laryngocele, right? Classical history, trumpet blower, increased pressure leading to laryngocele. Look at this one. There is this black, that is air-containing lesion. Again, this is the air-containing lesion. This is laryngocele. Okay, this is laryngocele. Next one, coming to orbit, some important structures identification. Right in the midline, going through the apex, this is going to be optic nerve. This is the muscle laterally. This is lateral rectus. Muscle medially. This is medial rectus. So lateral rectus and medial rectus. Related to the medial wall of the orbit are the sinus, which is ethmoid sinus. Okay, that is the ethmoid sinus. Look at this MRI showing the muscles. In the center we have, right in the center is the optic nerve. And these muscles, inferior is inferior rectus, lateral rectus, superior rectus and medial rectus. The one which you see alag se, right, superomedially, that muscle is the superior oblique muscle. Okay, that is the superior oblique muscle. Now, what do you see here? Compare the normal muscle size with this muscle size. The muscles are bulky. So, bulky extraocular muscles, look at the axial scan. You see that the belly of the muscle is widened. The tendon is not bulky. It is tendon sparing. So, bulky extraocular muscle sparing the tendon. It is like the bulky muscle with the narrow tendon. This is called as Coke sign, the Coca-Cola bottle sign, which is seen in thyroid ophthalmopathy. So, remember that thyroid ophthalmopathy, it causes the enlargement of extraocular muscles, but it spares the tendon. And the sequence is the first muscle involved is inferior rectus, then medial, superior and lateral rectus. Right? So, that is how is the sequence. It starts with the inferior rectus. And what are we seeing here? Frequently asked images. When you see this white calcification on the CT also, you are seeing this white calcification submandibular space mein. This is a stone. Salivary gland wala, so cyalolithiasis. Okay, this is cyalolithiasis. This is a stone. If you see the stone medial to the mandible, it is the submandibular wala stone. Right? If it is bahar ki taraf, then it is going to be parotid. Parotid is outside, submandibular will be inside. Compare it with this one. What are we seeing here? This lesion is the water density. That means a cystic lesion in the sublingual space. This is a ranula. Okay, this is the ranula. This is the water density. Okay, this is the water density. Yes, so that was about the important images correlating ENT and ophthal with radiology. And like I said, these are being asked very frequently in the recent exams. Hello friends, so now we are going to learn quickly about nuclear medicine and radiotherapy. So nuclear medicine and radiotherapy are branches which are different from radiodiagnosis. You have a PG, entire different PGs in both of them. And so nuclear medicine has various modalities like radiodiagnosis has X-ray, CT, MRI, ultrasound. Similarly, what are the modalities which are included in nuclear medicine are the scintigraphy, that is the nuclear scans, the radioisotope scans. We have SPECT and we have PET. Now, the common thing to all these modalities is basically here we use a radioisotope. So, in nuclear medicine, the basis is a radioisotope is used. That means an isotope which is radiologically active, that means it is emitting radiation. We send this radioisotope into the body. From the body, it emits the radiation, and that radiation is then captured by the detector, which is the gamma camera. So remember that in nuclear medicine, it is the gamma camera, also called as Anger's camera, scintillation camera, which is the detector which is used. So the various modalities that we spoke about in nuclear medicine is scintigraphy, then we have the PET scan, and we have the SPECT scan. Now, scintigraphy is the basic modality, like it is X-ray in radiodiagnosis. So this is like a two-dimensional. SPECT is like a three-dimensional scintigraphy. It is like CT. Remember, the full form of SPECT is single photon emission computed tomography, and PET is positron emission tomography. In PET, the P is positron, but in SPECT, the P is not positron, it is photon. Now, all these modalities in nuclear medicine, basically these are functional imaging. So, nuclear medicine is basically functional imaging. So, example, if I see a thyroid nodule on ultrasound, I cannot say whether this is hypofunctioning or hypofunctioning. I do a thyroid scan, a radioactive iodine scan, and then I get to know whether this is hyperfunctioning or hypofunctioning. So, all of these are functional imaging. We can have hybrid imaging as well, where we can combine a PET with CT, that is functional imaging with anatomical imaging. So PET-CT is an example of hybrid or fusion imaging. And PET-CT is now the investigation of choice generally to look for metastasis in any cancer. Now, how do we do these various modalities? So this is the gamma camera that you are seeing, which picks up the radiation that comes from the patient's body. So what do we do in these scintigraphy is, we send a radioisotope. The most common radioisotope used in scintigraphy is technetium-99m, the metastable form of technetium-99. It is bound to a ligand. This ligand depends on the site of interest. So ligand, like iodine itself, it's a ligand and a radioisotope also. It goes to the thyroid, and from there it emits the radiation. Technetium-99, when bound to pertechnate, it will go to the organ site of interest like the thyroid, the salivary gland, and from there we will get the radiation. So technetium-99 is bound to a ligand based on the site of interest, and it goes to that site, and from there it emits radiation. What radiation does technetium-99 emit? It emits gamma rays. Remember, it emits gamma rays. What is the energy of these rays? 140 keV. And then we get to know the function of the organ. Now, what is the half-life of this technetium-99m? If I give you options, whether it is 6 seconds, 6 minutes, 6 hours, or 6 days. So remember, logically thinking, it is 6 hours because it's a diagnostic radioisotope. The time should be good enough to complete the scan. It should not be very less. Scan complete nahi ho raha hai. It should not be very long, that there is a lot of radiation that the patient is emitting for a long period of time. Right, so all these nuclear scans basically have radiation exposure because we are using radioisotope. So based on the site of interest, we have the various scintigraphies. That is what we would be seeing as well. We spoke about technetium-99. The parent molecule from where it comes is molybdenum-99, and its half-life is 6 hours. It emits gamma rays. Now coming to the site-oriented various scintigraphies, what are the various renal scans that we do? So for the kidney, DMSA, remember the M and the S. The M and the S tells you that this is basically for morphology of the kidney and to look for the scar in the kidney. So a VUR patient, a child with recurrent UTI, we do MCU and we see the reflux. Now we want to see that how much scarring has happened in the kidney. So for scar, we do the DMSA. To look for the ectopic kidney as well, we can do the DMSA. DTPA on the other hand, remember P here, you can remember for mnemonic, P here stands for physiology, and physiology means function. So that means it's a functional scan for the kidney. Which function of the kidney does it tell us? The GFR, because it is eliminated by the glomerular filtration. MAG3, remember MAG is like mnemonic, you can remember MAG is more magnificent. That means glomerular also and tubular also. So that is why it tells us about the overall renal function. So best for renal function is MAG3. Now coming to the thyroid scan, we can do radioactive iodine scan. We can do the pertechnate scan as well. What isotope of iodine do we use? Let's have a quick look at the iodine isotopes. So we have iodine 123, 125, 131. The natural one is iodine 127, which is not radioactive. Now remember that this iodine 123 is used for the diagnostic scan, the radioactive iodine uptake scan. Iodine 125 is used in radiotherapy, like commonly used in CA prostate brachytherapy mein. And iodine 131 again is used for treatment for thyroid ablation. So remember, it is iodine 131 which is used for thyroid ablation, and it does this ablation by beta rays, not the gamma rays. It emits both beta and gamma, but beta is the one which has the therapeutic effect. Now, logically thinking, the one which is a diagnostic isotope is the one which has a shorter half-life in hours. The one which are used for treatment, they have a longer half-life in days. For 123, remember the first and the last number 13, it is 13 hours. For 125, remember 12 5s are 60, it is 60 days. For 131, remember it is 8 days for 131. Now, so what do we see in the thyroid scan? Most important, if there is a diffuse increased uptake, then the diagnosis is Graves' disease, thyrotoxicosis, hyperfunctioning, right? So when you have diffusely increased uptake, the black color in scintigraphy tells you that there is hotspot, increased activity. So diffuse increased uptake is Graves'. Diffuse decreased uptake, you are not seeing a lot of black uptake, then it is thyroiditis. Diffuse decreased uptake is thyroiditis. Diffuse increased uptake is Graves'. You can see here there is a cold nodule. Why do I call it cold? Because it is white. And there are hot nodules. This is toxic multinodular goiter. Multiple nodules which are dark. That means toxic, hyperfunctioning. And in thyroid, the cold nodules have more chances of malignancy as compared to hot nodules. Right, so this is thyroid scan. Remember, we will not do this thyroid scan in a pregnant female. No radiation exposure there. Now, next one, renal scans we have already seen. Coming to the bone scan. So, the bone scan that we do is technetium-99 bound to MDP, methylene diphosphonate. Remember, in bones we have calcium phosphorus. So, diphosphonate scan basically is for bones. Okay, diphosphonate scan is for bones. And wherever there is new bone formation, we get a hot spot in the bone scan. So it can be seen with blastic metastasis, not the lytic metastasis. Then we have fracture, where there is callus formation, osteomyelitis. Anywhere where there is new bone formation, even in pages, we will get a hot spot. Very important, remember that what gives a cold spot in the bone scan is multiple myeloma. Multiple myeloma is lytic lesions, plasma cells, there is no new bone formation, and it gives a cold spot. That's why the alkaline phosphatase levels are also normal in multiple myeloma. Remember that. Right. And for bone metastasis, bone scan is not like the best investigation because it cannot pick up the lytic mets. So we can do the PET scan, or MRI is a better investigation for bone metastasis. Now, what is the super scan? Super scan is where the bones, all the bones are showing increased uptake, and the kidney, which is normally visualized in these scintigraphies because it excretes the isotope, that is not seen. So, diffuse increased uptake in the bones without kidney visualization, that is a super scan. What are the causes of super scan? It is metabolic bone disorders like hyperparathyroidism. It is diffuse bone metastasis. Remember, hyperparathyroidism, diffuse bone metastasis, that gives a super scan. What do you see here? In the sacrum, this H sign that is called as Honda sign, that is suggestive of sacral insufficiency fracture. So remember, the H sign is indicating the sacrum insufficiency fracture. Now coming to technetium pertechnate scan, technetium-99 pertechnate scan. Now this pertechnate is picked up by the thyroid gland, by the stomach mucosa, and even by the salivary gland. So it can be used in all these conditions. Now, where do we have this ectopic gastric mucosa? In which condition? Meckel's diverticulum. So for Meckel's diverticulum, the investigation of choice is technetium-99 pertechnate. The ectopic gastric mucosa will take up this pertechnate. So here you can see that there is an uptake in the left upper quadrant, suggesting the stomach. Similar to stomach, in the right iliac fossa, we see the uptake. So right iliac fossa, Meckel's diverticulum, ectopic gastric mucosa. Okay, so technetium-99 pertechnate scan for Meckel's. And which salivary gland tumor shows the hot spot? Remember, Warthin's tumor is the salivary gland tumor which shows the hot spot on the pertechnate scan. The rest of them are the cold spots, like the malignant nodules in thyroid are cold. So remember that Warthin is on a war. That means very hot, very aggressive. Warthin is on a war. It is hot spot. Coming to the cardiac scans, the cardiac nuclear scans. First one, what do we do for cardiac perfusion? That is ischemia. And what do we do for cardiac myocardial infarct? So for ischemia, for perfusion, commonly used is the thallium scan. And in thallium scan, if we see a reversible defect, then it suggests it is ischemia. Irreversible will be infarct. So similar to thallium, we can also use tetrophosmin and we can use the cystamebi for myocardial perfusion. What do we use for myocardial infarct is technetium-99 pyrophosphate scan. Pyrophosphate scan because infarct shows a hot spot on the pyrophosphate scan because infarct is dead. So it accumulates the pyrophosphate. It is not able to metabolize that. So it shows a hot spot. So you can remember this as pyro is like pyre, which is fire, which is hot. So pyrophosphate gives a hot spot. Next one, what is the scan that we do for left ventricular function? So the nuclear scan that we do for LV function is the MUGA scan, multiple gated acquisition scan using RBCs. But the most accurate for LV function is cardiac MRI. Most accurate is cardiac MRI. Now, what is the investigation that we do for myocardial viability or to detect hibernating myocardium? Now, the best for cardiac viability is the PET scan, where we combine the metabolism with the perfusion scan. So, for metabolism, we use FDG. For perfusion, we can use rubidium, we can use ammonia, and we look for the match and the mismatch. Now, when it is the ischemic myocardium, then only it will take up this FDG. A normal myocardium does not use glucose. A dead myocardium will not use glucose. There will be no uptake. Ischemic myocardium will pick up FDG. So, if there's FDG uptake, we know that it is ischemic. It is hibernating myocardium. To differentiate whether it is normal or infarct, then we combine it with perfusion. Normal will have normal perfusion, infarct will have no perfusion. Right? So remember that PET is the best for hibernating myocardium. Now coming to HIDA scan. What is this HIDA scan used for? HIDA, it is hepatic immunodiacetic acid, which is used for the biliary tract. So what happens? It is taken up by the liver. From the liver, it goes to the bile duct, and from the bile duct, it goes to the bowel. So, if the HIDA is coming into the bowel, we know that the biliary tract is patent. So, it rules out biliary atresia. So, this investigation is good for ruling out biliary atresia. Next, it is the gold standard for acute cholecystitis. Gold standard for acute cholecystitis, where we will not see the gallbladder because it is blocked. So, no HIDA going there. And third, it is the most sensitive investigation for bile leak. It is the most sensitive. Even though it is not good for localizing the site, but it is very sensitive for telling that whether the bile leak is present or not present. We will see the HIDA going out of the biliary tract, accumulating at abnormal places. So, this is the image showing the HIDA where you have the liver uptake. And then you see here, there is the gallbladder seen, the bile duct, and then it comes into the bowel as well. This is a normal HIDA scan. Now, this one, where in the liver you see the hot spot. Remember the sulfur colloid scan. Sulfur colloid scan is used for which liver lesion? It is used for FNH. FNH is the one which shows the hot spot. On sulfur colloid scan, Why? Because the sulfur colloid is taken up by the reticuloendothelial system cells, and in the liver, these cells are the Kupffer cells. And Kupffer cells are present in FNH, not in HCC. HCC is hepatocellular. Hepatocytes ka carcinoma, it is not the Kupffer cells. Similarly, this will also show the hotspot with splenosis, splenunculus, wherever there is extra spleen, or even with occult abscess, which will have macrophages, which are the cells of the reticuloendothelial system. Now, going to the MIBG scan, MIBG is the nuclear scan which is done for pheochromocytoma or extraadrenal pheochromocytoma, that is paraganglioma. So, when we are not able to localize it in the adrenal by MRI, we can do MIBG scan. So, wherever the pheochromocytoma is located, that will be localized, because we know that 10% of pheochromocytomas are extraadrenal. Which PET scan can we use for pheochromocytoma? We have the DOPA PET. Remember DOPA, dopamine gives norepinephrine, epinephrine, that's pheochromocytoma. So remember that DOPA PET is for pheochromocytoma. Correlate this with MRI. We have seen that pheochromocytoma shows light bulb sign on T2 weighted MRI. Now coming to the PET scan. PET scan is positron emission tomography. Positron emitter radioisotope is used. The most common that we use here is F18, which is the positron emitter. Okay, it is the F18 which is the positron emitter that is used here. Why F18 is used commonly? Because it has a good enough half-life to complete the scan. What is the half-life of F18? It is approximately 2 hours. Technetium is 6 hours. This is 2 hours, approximately 110 minutes. So when we say FDG PET, remember the F there is the radioisotope that we are using. The DG is the deoxyglucose, which is the most common ligand which is bound to this F18. Why do we use DG as the most common ligand? Because the primary indication for PET is for cancer, the staging of cancer. So what happens is, in the cancer cells, we know that there is Warburg effect. Cancer cells, they take up more glucose, and so what will happen? They will take up more deoxyglucose as compared to normal cells. This deoxyglucose, when it goes into the cell, so this FDG, when it goes into the cell, it forms FDG6-phosphate rather than the regular glucose 6-phosphate, and it cannot be metabolized further. It gets trapped, and from there the radiation is emitted. Right, so remember, it's basically the trapping of this FDG6-phosphate which is being utilized in staging the cancer. So the cancer cells, we call them are FDG avid. That means they like FDG, they take up a lot of FDG. Remember some exceptions here. The tumors which can be PET negative, especially the low-grade tumors which are like normal cells. So that is bronchoalveolar carcinoma in the lung and typical carcinoid, that is a well-differentiated carcinoid. These will be PET negative. So that's the principle of PET scan. Now, the actual principle of PET scan we have seen in basics also is the annihilation coincidence circuit. Okay, the annihilation coincidence circuit. What is the annihilation? So when we give FDG, F going into the body, it emits the positron. This positron interacts with electron in the body. Positron, electron, they destroy each other, annihilate each other. The energy gets transferred and it creates two photons which go in the opposite direction. So basically an angle of 180 degrees. So the energy of each of these photon is 511 keV. So there is a dual photon peak which is generated here. Now these two photons which are generated, they go and hit the detector. Now when this pair hits the detector at the same time, that is coincidence, that is when the detector picks up these gamma photons. So this is annihilation coincidence circuit, which is the principle of PET scan, a previously asked question. So PET also has radiation exposure because we are using radioisotope. Most common indication we said cancer staging, can also be used to look for response to treatment and recurrence. Right, we will see that the FDG avidity is decreasing or the FDG avidity is increasing to look for response or recurrence. So look at this image. What is this investigation here? Asked many times in the exam. So when you see a CT image, the white bones, with the orange color, remember that it is PET-CT, combined PET-CT, which is an example of hybrid or fusion imaging. This is PET-CT. This is the normal routine CT where you see the gray scale. Now coming to some specific PETs that are used. So where do we use C11 methionine PET? C11 methionine PET is used for brain tumors, right? Brain tumors, a lot of cell membrane turnover, the C11 will go there. Choline PET, PMSA PET, remember this is prostate. P for prostate and choline is also for prostate cancer. DOTA knock, DOTA talk, this PET, basically the OC tells you that this is octreotide, and octreotide we know is related to somatostatin. So remember somatostatin, hormone, endocrine. So remember these are used for neuroendocrine tumors like glucagonoma, somatostatinoma, pheochromocytoma. So similarly, somatostatin receptor scintigraphy is also used for neuroendocrine tumors. But remember that this is negative for which tumor? It is negative for which neuroendocrine tumor? Insulinoma. It is negative for insulinoma. Then we have sodium fluoride PET, which is used for bone metastasis. Sodium fluoride PET is for bone mets. We have already seen DOPA PET, dopamine wala, which is for pheochromocytoma. So these are some of the specific PET types that we should be knowing. So that was about nuclear medicine. To add on one point related to SPECT. Now remember that there is something called as HMPAO SPECT. HMPAO SPECT, remember, is used for cerebral perfusion, not for the lung or the myocardial perfusion. It is used for cerebral perfusion. It can help us identify brain death. What sign do we see in brain death? It is the hot nose sign. Okay, there will be increased uptake in the nasal area. Brain में कोई uptake नहीं होगा. So this is used for cerebral perfusion. So this was about the important points in nuclear medicine. So now learning about radiotherapy. As the term says, radiotherapy is using radiation for treatment. So we know that radiation is damaging to the cells, it kills the cells. So we use this as an advantage and in killing the cancer cells. Now, according to the law of Bergoni, the cancer cells which are more dividing are more susceptible to radiation. So they are damaged more. So one of the recent NEET PG question that normal cells and cancer cells are not equally damaged. Cancer cells will be damaged more because they are more dividing. And second, their repair mechanism is also affected. Now, what are the types of radiotherapy? Now, the types of radiotherapy is teletherapy. Then we have brachytherapy. And we have specialized types like the stereotactic radiosurgery, which includes the gamma knife, the cyber knife, right? So those are the various types of radiotherapy. Now in teletherapy, as the term says, tele, like telephone, talking to someone at a distance. Telescope, seeing something at a distance. So tele basically means at a distance. So the radiation source is away from the patient's body. So this is also called as external beam radiotherapy, that is EBRT, because the beam is coming from outside. So this is teletherapy. Brachydactyly. Brachy means short. So here the radiation source is at a short distance from the patient's body. It is near the patient's body, it is on the patient's body, or it is inside the patient's body. Inside the patient's body, basically inside the patient body, we can use the seed brachytherapy, that is where we use an implant, or it could be a systemic brachytherapy. So thinking logically, the seed or the implant brachytherapy will be used when the tumor is accessible, like carcinoma cervix, we can put the implant, right? So accessible sites, we use the implant therapy. When it is a diffusely spread cancer, inaccessible sites, then we use systemic brachytherapy. That means the entire body is where the radioactive agent is going, right? So example of systemic, using iodine 131, right? So it is given either oral or IV. The agent is given oral or IV in systemic brachytherapy. So iodine 131, which is used for thyroid ablation in Graves' thyroid cancer. Then we have phosphorus 32, which is used for treatment of polycythemia vera. Then we have strontium or samarium, which is used for bone pain due to bone metastasis. All these are systemic brachytherapy. And remember that the ones which are used for systemic brachytherapy are the radioisotopes which generally emit the beta radiation. So that the beta particles, they stay in the body and they kill the cancer cells in the body. So which are the pure beta emitters? Remember PSY, Psychiatrica PSY, phosphorus 32, strontium and yttrium, remember, are pure beta emitters. Iodine 131 is not a pure beta emitter. It emits beta plus gamma rays. Okay, it emits beta plus gamma rays. So this is about the brachytherapy. Now stereotactic radiosurgery, gamma knife, we will talk about that as well, which is used for the inaccessible small brain lesions. And then we have a development which is stereotactic body radiotherapy, which uses LINAC, and it can be used for the rest of the body as well. So in the seed or implant brachytherapy, the implant that we use, it can be a temporary implant or it can be a permanent implant. Now thinking logically, the ones which have the short half-lives are the ones which are used for permanent, because automatically their radioactivity will go, so we don't need to remove them. Temporary ones are the long T-half. So a question comes that which of these are used as permanent implants? So remember, cigar P is the mnemonic. When you pee cigar, smoke, then it causes permanent damage to the lung. So remember cigar P, that is CIGYRP, that is cesium-131. Remember, it is not 137. Then you have iodine 125, which we saw in nuclear medicine. It's a permanent implant commonly used in CA prostate. Then we have gold, yttrium, R for radon 222, and we have palladium, which are permanent implants, right? So these are the temporary and the permanent implants. Other ones which are commonly used in brachytherapy, we have iridium, we have cesium-137, cobalt. These are used in temporary implants as well. Now, going to the next one. So look at this image here, the LINAC. Okay, so in EBRT, the types, when we saw the types of radiation, EBRT, basically we can use cobalt machine, and now which is commonly used is LINAC. That is linear accelerator is commonly used. And remember that this LINAC produces electrons and X-rays. It produces electrons and X-rays. So in the LINAC, we have a fast moving electron beam which produces these X-rays, and there is the electron beam, and that is linear accelerator. This is the one which is most commonly used for radiotherapy now. Now what is this one? This is something called as after loading technique. And the question asked is, where do we use after loading? After loading is used in brachytherapy. So basically, to avoid radiation exposure to the person operator there, what do we have is, we have these radioactive sources containing cables. They deliver the radioactive source into the patient's body. So the manual handling of the radioactive source is not there. So it decreases the radiation exposure. So remember, that is after loading, which is used in brachytherapy. Now, what are the various agents that are used for radiotherapy? Basically, which radiation? Most commonly used is X-rays now, because we said that LINAC is the most commonly used now, which produces X-rays. Then we have gamma rays also, like cobalt-60, the cobalt machine, it acts via gamma radiation. Then we can also use the proton beam for radiotherapy. The advantage with proton beam is that it gives pencil beam like targeted therapy. That means it targets only the tumor. The surrounding normal cells are not affected that much, while X-rays and gamma rays cause damage to the superficial, the surrounding tissues as well. So for deep-seated tumors, we can actually use proton beam because it will go to the tumor directly and not the superficial structures will be damaged. Other thing that which can be used is the electron beam. Now this electron beam has less penetration as compared to the rest. So this is used for superficial tumors like the skin cancers, like mycosis fungoids. It is used for intraoperative radiotherapy. Intraoperative, the tumor becomes superficial because we have opened up. So electron beam is the most commonly which is used there. The disadvantage with X-rays and gamma rays is that they cause a lot of skin erythema. That is the most common side effect with radiotherapy. They affect the superficial structures also. So remember that this proton beam, how is it produced? It is produced by cyclotron. Okay, cyclotron is what produces protons. Now out of this, which is the one which gives the Bragg peak? So frequently asked question, Bragg peak is seen with the proton beam. What is the Bragg peak? So when we give proton, as it goes into the body, initially there is no radiation which is given to the tissues, and when it reaches the tumor site, suddenly there is a peak which comes in the radiation dose that is delivered to the tumor, and then again it falls. So the advantage we said with proton beam that all the radiation is targeted at the tumor. So that is the Bragg peak. So remember, Bragg peak BR is PR. Bragg is seen with PR, that is proton. In contrast, if you look at the X-ray, it has maximum dose deposition superficially itself. That's why it causes a lot of skin erythema. Now, coming to, so what are the radioisotopes which are used for radiotherapy? They emit this various radiation, and let's have a quick look at their respective half-lives as well. So for remembering this, you can keep saying this like a poem, like a rhyme, like a song. IORECOCC. Okay, keep saying that. IORECOCC. So out of that, the II ones are the ones which have their half-life in days. The COCC are the ones which have the half-life in years. We are talking about iodine 125, iridium 192, cobalt 60 and cesium 137. So IORECOCC. Iodine 125 we have already seen, the half-life is 125 ka 12 into 5, that is 60 days. So this is the ascending order of the half-life. Agar iska 60 days hai, to iridium ka more than 60 days, that is 74 days. Cobalt cesium, the half-life is in years. First comes cobalt, that is 5 years, and cesium is the next, that is 30 years. Right? So remember IORECOCC, days and years. Iodine 125, 60, then 74, then 5 and then 30 years. Maximum half-life is with radium 226. So when you write 226 ulta, this becomes 622. Add a 1, this is 1622 years. Radium was the first isotope to be used for radiotherapy in humans. But now it is not used because it produces radon, and radon causes lung cancer, and that is why it is not used now. So these are some of the important half-lives that you should know. Adding on to the list, phosphorus 32. Remember, phosphorus 44, it is 14 days for phosphorus 32. For yttrium, it is 2 days for yttrium. Technetium we have already seen is 6 hours. And F18 is 2 hours, 110 minutes. What is this form of radiotherapy? So when you see a frame around the head, that is the Lexell's frame. The Lexell frame which is used in gamma knife. Okay, this is the Lexell frame which is used in gamma knife. So gamma knife is basically a form of stereotactic radiosurgery. Who invented this? Lars Lexell. Right, a neurosurgeon who saw that there are some lesions in the brain which are inaccessible, difficult to operate. So he found out that a better way is focus all the gamma rays at that lesion so that it ablates that lesion. Right, so Lars Lexell invented gamma knife, and remember that gamma knife is a misnomer. Actually, there is no knife there. It is just the radiation which is focused on the lesion in the gamma knife. And this is used for brain lesions like trigeminal neuralgia. Commonly used, gamma knife is the treatment. Pituitary adenoma. This is also used in the treatment of meningioma, and also for vascular malformations like AV malformation. Remember, gamma knife we will not use in the treatment of TB, the tuberculoma in the brain, because TB is an infection and we need to give anti-cox therapy. Anti-tubercular treatment is what we need to give for TB. Now, how is this gamma knife done? So, first we put this frame around the patient's head. Then we take the patient to MRI. and we localize that where the lesion is. This frame has the XYZ coordinates. So on this XYZ coordinates, we localize where is the lesion localized. Then we take the patient to gamma knife. On the coordinates localized, we focus all the multiple beams of gamma rays there. So on the localized lesion, we focus all the gamma rays, and that is what ablates the lesion. So gamma knife will be identified by this frame around the patient's head. जैसे gamma knife है, वैसे दूसरा जो है वो है cyber knife. Now the difference is gamma knife uses gamma rays. Cyber knife uses X-rays which are produced in LINAC. The advantage is this is frameless. We do not need to use the frame in the cyber knife, and it can be used for the rest of the body also. So these are the treatment which are used for localized early cancers, right? It is for one site cancer. It is not for a cancer which has already spread, like lymph node mets ho gaya, lymphangitis carcinomatosis ho gaya. We don't use in the cancers which have already spread, but the early localized cancers. Now, in which cases do we use this prophylactic craniospinal irradiation? So in tumors where we know that this tumor has high chances of going to spread to the spinal cord, in those cases we use this prophylactic craniospinal irradiation. Which lung cancer? It is the small cell lung cancer which metastasizes. Brain tumors which have drop metastasis, that is medulloblastoma, ependymoma. These are the ones which have drop mets. And the blood cancer, that is ALL. In these cases, we use prophylactic craniospinal irradiation. What is the first hormone deficiency that we see with this? When you give the cranial irradiation, the first hormone deficient is the growth hormone. Okay, it is a growth hormone which is the deficient first. Can you tell me that what is the most common radiation-induced cancer? Yes, it is leukemia. What is the radiation-induced thyroid cancer? It is papillary carcinoma. Okay, remember papillary carcinoma post-radiation. Now coming to the 5 hours or the 6 hours of radiobiology, which are harvested, basically taken advantage of in fractionated radiotherapy. Right, so what is fractionated radiotherapy? Rather than giving all the radiation dose at once, we give them in fractions. So this takes the advantage of the 6 hours of radiobiology, that is repopulation, repair, redistribution, radiosensitivity, reoxygenation, and the 6th hour, the new one, is the reactivation of the immune response. So fractionated radiotherapy takes advantage of these 5 or 6 hours of radiobiology, right? So the normal cells can repair themselves because we are giving only a fraction of dose. The cancer cells redistribute in the cell cycle phase, so that if they are sensitive, if they are resistant on day 1, they can go into the sensitive phase on the next day. Reoxygenation happens. All these are the advantages. So fractionated radiotherapy. Now, so when I talk about redistribution, so tell me which is the most radio-resistant and which is the most radio-sensitive cell cycle phase. So S is the one which is the most radio-resistant, because here the cell is not actively dividing. The law of Bergoni says that the cells will be actively dividing, then the radiotherapy will act the best. The most radio-sensitive is this G2M phase. Okay, the G2M phase. So let's have a quick look at the most radio-sensitive and the most radio-resistant. The cell cycle phase, most radio-sensitive is G2M, resistant is the S. Which is the blood cell which is the most radio-sensitive? It is lymphocyte which is affected the first. Most radio-resistant is the platelet. Which is the most radio-sensitive tissue? That is bone marrow. We see the bone marrow suppression as one of the early effects of radiation. Most resistant is the neurons, previously asked question, because they do not divide. Also here, remember that the dividing cells like GI mucosa, the spermatogonia, the gonads, they are also radiosensitive. Neurons are the ones which are radio resistant. Okay, neurons are the ones which are radio resistant. Now, which are the radiation sensitizers, protectors, and potentiators? So, remember that for radiotherapy to act, we need oxygen. There should be no hypoxia. And that is why before a radiotherapy, a PET scan which is done is called as meso-PET, which is basically for hypoxia imaging, right? So, oxygen is the most potent radiosensitizer, hyperbaric oxygen. Also remember the chemotherapy drugs like 5-fluorouracil, cisplatin, gemcitabine, all of these are radiosensitizers. Which is the radioprotector? Radioprotector is emifostin, which you must have also read in Pharmac. It is used for cisplatin ka nephrotoxicity kam karne ke liye. But what organ does emifostin does not protect? The CNS, because it does not cross the blood-brain barrier. Other radioprotectors are the antioxidants. So basically which are scavenging the free radicals, so preventing the damage. So antioxidants, pentoxyphylline, these are radioprotectors. Which are the radiation potentiators? The chemotherapy drugs which have the side effect of radiation recall. So when we give radiotherapy and after that we give chemotherapy with these drugs which are anthracyclines, doxorubicin, daunorubicin, at the site of radiation there is erythema which develops. So remember that these are radiation potentiators. They increase the effect of the radiotherapy if given together as well. And they can also show the side effect of radiation recall. The anthracyclines, that is doxorubicin and daunorubicin. These are the radiation potentiators, right? So that was about all the important points in radiotherapy. I hope this is now easy. Thank you so much.